NoHMSIC. First of all, we thank God Almighty because of His blessings and grace that our first day conference has been done. And we can attend and participate in the second day NoHMSIC entitled Tropical and Infectious Disease, on-site and virtually. Started from yesterday, 13th of October, until now, Saturday, 14th of October 2023. My name is Christine Ferawati Sibuya. It is a wonderful and precious chance for me to be your master ceremony in this second day NoHMSIC. The Honorable Mr. Leo Simanjuntak, Dean of Medical Fakultas Universitas HKBP Nommensen, the Honorable our keynote speaker and symposium speaker, the Honorable our all participants, welcome to our second day, second NoHMSIC. As day before, I would like to take a moment to express our immense gratitude to the committee who have made this seminar possible. Without their support, we would not be here today. We are truly thankful for their efforts and contribution toward this event. We have an exciting lecture and symposium for today, and we hope that you will find their presentation and discussion informative and engaging. So enjoy this second day, second NoHMSIC. Before begin, I'd like to have a few moments to explain the rules for today's conference. First, please make sure your cell phones are on silent mode so we don't disturb the speakers and other attendants. We encourage you all to participate in the discussion and ask questions related to the seminar topic during the Q&A session at the end of each session. Please make sure you keep your question brief and to the point to allow a productive discussion. We request our attendees to refrain from any side conversations during the seminar, as it can be distracting for the other participants. Before we start our conference, let us pray in accordance. May God take this rewarding event run smoothly. I will lead in Christian, and for another religion may pray in their own religion. Let us pray. Dear Lord, we thank you for this beautiful morning and for all your blessing in our life and for our first day, second NoHMSIC yesterday. May Lord bless this second day, second NoHMSIC, so it can give benefit to our lives, knowledge, and experience. In Jesus' name we pray. Amen. A happy audience. Before we start our conference today, I will read out the agenda we have this morning until evening. Our agenda today is as follows. Plenary lecture with moderator, symposium with moderator, and the closing of NoHMSIC. Excellencies, ladies and gentlemen, now we come to our main program. The first plenary lecture from Mr. Deepsika Agrawal, who will be held by our moderator, Mr. Surjit Singh. Oh, I'm sorry, Mrs. Deepsika Agrawal, who will be held by our moderator, Mr. Surjit Singh. Mr. Surjit Singh, the time and place are yours.
Good morning, ladies and gentlemen. First of all, I would like to extend my thanks to the MC who has given me an opportunity to be the moderator for this event, for this conference. Well, this morning we are having a speaker from India, Dr. Deepsika Agarwal. Yes, I think, is she online now? Can we hear Dr. Deepshika? Good morning, Dr. Deepshika Agarwal.
Good morning, Dr. Sujit Singh.
Okay, Madam, ladies and gentlemen, allow me to read the biography of Dr. Deepshika Agarwal. She is Director and Corneal Anterior Segment Consultant, MGM Eye Institute, Raipur in India. Well, in brief, as a commitment to the cause of eradication of blindness in India, which is based with poverty and underdevelopment, undertook intensive social work in the field of eye care for about 32 years. That means Dr. Deepshika has been dedicating herself for the last 32 years. Here have been instrumental in the conceptualization of a comprehensive eye care institute to make available high-quality eye care to all, irrespective of financial status. And of course, she is founder, member, and trustee of Mickey Memorial Trust, through which MGM Eye Institute started at Raipur in 2004 as a tertiary eye care center of international standards, with the vision to provide accessible, acceptable, affordable, appropriate, comprehensive, quality eye care services to all. And the mission is to provide the most advanced eye care to all the segments of the society, especially the underprivileged. Well, let me read about her, Dr. Deepshika. Fellowships, she is cornea and anterior segment. She has got fellowship for cornea and anterior segment from L.V. Prasad Eye Institute, Hyderabad, and of course, IOL, microsurgery at Aravind Eye Hospital, Madurai, and FICO training from Lakshmi Eye Institute, Panvel, Mumbai, with Dr. S.S. Haldipurkar. So that was the biography of Dr. Deepshika Agarwal. Well, Dr. Deepshika, we request you to kindly present your presentation this morning. Time is yours. Thank you very much.
Thank you, sir, for an elaborate introduction. Thank you very much. I am sharing my screen now. बड़ा कर लो। So good morning, everyone. Thank you very much to the organizing committee, scientific committee of Nommensen Health and Medical Science International Conference. A special thanks to Dr. Sujit Singh for inviting me and giving me this opportunity. And good morning, all. I'm talking about the ocular tuberculosis. So all as we know, this is a clinical disease which is caused by Mycobacterium tuberculosis, and tuberculosis is one of the top 10 cause of the death worldwide. That's why World Health Organization has declared it a global emergency. And the global threat is because of emergence of multi-drug resistant and extensively drug-resistant global threat. So the tuberculosis was identified first in 1883. In ocular tuberculosis, there are 3 types of transmission. The first one is direct ocular infection from an exogenous source like contact with the lids or conjunctiva. This is the primary ocular tuberculosis. Second mode of spread is hematogenous, which is by the either pulmonary or extrapulmonary site through Mycobacterium tuberculosis. This is a secondary ocular tuberculosis, which is the most common mode of transmission. And third one is the hypersensitivity reaction because of the exposure of tuberculosis antigen to the structures of eye. So these three modes of transmission of the disease, most common is the hematogenous. So according to WHO, around 10.4 million people fall ill and nearly 1.8 million people die from the tuberculosis each year. So the global burden of the tuberculosis cases are more in the Southeast Asia, nearly 44%. Out of that, 27% are affected in India, 9% in China, 8% in Indonesia, and 6% in Philippines, 6% in Pakistan. In India, in North India, if anterior uveitis cases which are presenting are 9.86% because of tuberculosis. So, ocular tuberculosis has been classified according to the anatomical location. Either it is extraocular tuberculosis or intraocular tuberculosis. In extraocular tuberculosis, the structures which are affected like orbit, where the most common signs are painful proptosis, where the protrusion of the eyeball, and because of this sometimes the patient loses the sight, eyelid swelling, mechanical ptosis, when it is in the lid it causes the ptosis, and intermittent periorbital swelling, chemosis also can occur, and this is most common in children. This is the case of orbital tuberculosis. If eyelids are also affected, this is again in children. In this, the sign like lupus vulgaris with apple jelly nodules. This is the picture which is showing lid abscesses can occur and draining sinuses like this. This is the draining sinuses. Chronic blepharitis when the lid margins are affected, where near the eyelashes there is the scales which causes the this chronic blepharitis, and sometimes we find the atypical chalazion. So if these signs we are seeing in children, we have to thought about the case of extraocular tuberculosis of eyelid. Lacrimal gland also can be affected, which can because of the dacroadenitis. Conjunctiva also can affected. It can cause redness or the mucopollulant discharge. This is the dacroadenitis. This is the gland which is affected by the tuberculosis. Cornea also, all we have seen cases of flectular conjunctivitis. This is a hypersensitivity reaction to the antigen. This is the picture of flectular keratoconjunctivitis. Interstitial keratitis can also occur either in the form of sector peripheral stromal infiltrate with vascularization. This picture is showing, this is the picture of interstitial keratitis and stromal infiltrate, which this picture is showing. Sclera also can be affected, which is anterior scleritis or scleral abscesses, which may be a chronic or it can be necrotizing. This is the sclera which is causing the scleritis. So tuberculosis can affect all these structures. This is diffuse picture. This is the scleral abscess. This picture is showing the scleral abscess. Now we will see how the intraocular tuberculosis occur. So it can occur in the form of anterior uveitis. In this there are the granulomatous with the mutton fat capes. All we know how it looks like, and sometimes it is with the granulomas. It is copies or the basaka. Copies occurs in the pupillary margin, while the basaka in the periphery or the surface of the iris. broad-based posterior synechiae, complicated cataract, and in children, sometimes it is a band-shaped keratopathy. So these are the features of intraocular tuberculosis. This is the broad-based synechia and mutton-fed capes. These are the larger capes which is looking at the posterior surface of the cornea. These are the synechiae, where the iris is adhere with the anterior capsule of the lens and because of the inflammatory reaction. So these are the pictures for these cases. Intermediate uveitis also can occur. It can be a mild or moderate uveitis, and it gives the feature of snowballs or snow banking, where the exudates are collected in the pars plana and it looks like a snowball or banking. And it can cause the peripheral vascular sheathing also. The second form is the posterior uveitis, which is most common presentation in ocular tuberculosis. It can be in the tubercular granuloma. Granuloma can be solitary or multiple, and multifocal choroiditis may progress to serpiginous like choroiditis but doesn't extend to the optic disc. And vitritis also can occur. These are the few pictures. This is a multifocal choroiditis. Here you are seeing the lesions, which is yellowish white in the choroid, and this is a tubercle, choroidal tubercle. This is a granuloma. So these are the differentiation picture whenever we are doing the comprehensive examination
Recording
of the
in
patient.
progress.
So, if these pictures we are seeing, we have to thought about the case of tuberculosis. Tuberculosis can affect the retina through the choroidal extension in the form of focal tubercle, subretinal abscesses, or diffuse retinitis. Or it can be occlusive retinal vasculitis with neovascularization. It can be active or healed choroiditis lesions. These are the pictures which is showing. This is the vasculitis which we are seeing here in the periphery and sclerosed vessels. It can affect the optic disc also. In this we can find the disc edema, neovascularization, or disc tubercle. This also can cause a dreaded infection like endophthalmitis because of the subretinal abscess, which can be perforate and go into the vitreous cavity and can cause the endophthalmitis. So this is optic disc neovascularization. This is the case of tuberculosis. So when we can suspect the case of suspicious of tuberculosis, when during our examination, when patient comes to us, if we are seeing the broad-based posterior synechiae or the retinal vasculitis with or without choroiditis, serpiginous like choroiditis, or choroidal granuloma with multifocal choroiditis. If these features we find during our examination, we have to think about the ocular tuberculosis. So investigations are very important because early diagnosis can prevent the further complications. So what the test we should ask to the patient? First is the tuberculin test. All we know is the Mantoux test, and interferon gamma release assay, T-spot, and quantiferon TB gold test. This is more specific than TST. Also, we have to advise to the patient for chest X-ray or HRCT test to reveal the hilar lymph nodes and pulmonary tuberculosis. Anterior chamber tap or vitreous sample for the PCR, but the sensitivity of this test is 77% while the specificity is 92%. The other investigation are the fine needle aspiration biopsy or tissue biopsy for the culture of Mycobacterium tuberculosis. This is a gold standard, but it is difficult to collect the sample, risky procedure, and it takes time to get the report in 10 weeks. So these are the blood investigation, other X-ray or another CT scan. But for the ocular investigation, we should do the fundus fluorescein angiography to rule out any active vasculitis or any neovascularization in the retina, capillary non-perfusion areas. Apart from that, we have to do the optical coherence tomography to rule out any cystoid macular edema, because this ocular tuberculosis can cause the macular edema which affects the vision. Ultrasonography, these can also be done to rule out any tractional detachment of the retina or any vitreous hemorrhage because of the ocular tuberculosis. So what is the management? So first is very important to diagnose the case on time to prevent the further complications. The management of the tuberculosis is similar to the pulmonary tuberculosis. The treatment consists of 4 drugs regime, which is administered in 2 phases. Rifampicin, isoniazid, pyraminazide and ethambutol daily for 2 months, followed by the rifampicin or isoniazid for 4 months. If the patient fails to respond in 3 to 4 weeks, consider the multi-drug resistance, which is a very important problem of treating the patient of tuberculosis. And the management should be continued in conjunction with the infectious disease specialist. And steroids also plays very important role, but it should be given with very cautiously. Steroids are to reverse the insult from the granulomatous inflammation and help to prevent a delayed type of hypersensitivity reaction to tubercular antigen. Steroids are used cautiously along with the anti-tubercular medicines. If the ocular tubercular patient presents with the following, then along with the oral steroid and anti-tubercular treatment, like if it is anterior uveitis, then we have to give the topical steroids in a proper dose as well as the cycloplegic medicines. So it will dilate the pupil and relax the ciliary muscles. Second one, if the patient comes with the retinal vasculitis and neovascularization, so the pen retinal photocoagulation is indicated. This is the picture of tuberculosis with retinal vasculitis. Here we are seeing the hemorrhages, sheathing and every neovascularization of the optic disc. And this is the case when after the laser treatment. So the PRP laser has been done to prevent the further complication and to save the sight. So what the complications can occur because of the ocular tuberculosis? It can cause the tractional retinal detachment and it may need the vitreoretinal surgery. ATT drugs are also cause some side effects like ethambutol, isoniazid and linezolid can cause the toxic neuropathy. That's why it is very important the evaluation of the eye in every 4 weeks. So, what are the important pearls to identify the ocular tuberculosis and investigation and management? So, most common form of ocular tuberculosis is the spread is hematogenous spread. Ocular tuberculosis can involve any part of the eye and it can occur with or without evidence of pulmonary or extrapulmonary tuberculosis disease. The most common ocular tuberculosis manifestation is granulomatous uveitis, and the most common presentation is posterior uveitis. Most typical lesions related to ocular tuberculosis are choroidal granuloma, occlusive retinal vasculitis, multifocal serpiginous like choroiditis, and the gold standard for the diagnosis is the identification of Mycobacterium tuberculosis in culture. However, it is very rarely possible. PCR of ocular fluid, a recent alternative to culture but not widely available. Diagnosis in most cases is presumed ocular tuberculosis when we are who's finding the clinical signs, but the other signs are not there. So we treat the patient as a presumed ocular tuberculosis. Ocular finding must be supported to context the risk factor history, chest radiography findings, and TST or IGRA testing. Negative tests do not rule out ocular tuberculosis. This is very important when we, as a clinician, when we see the patient and have to take a decision, so this should also we should keep in mind. The treatment of ocular tuberculosis is the same as for the pulmonary tuberculosis, and concomitant steroid therapy is often required. These are my references. So thank you very much for your patience hearing. Thank you.
Well, thank you very much, Dr. Deepsika Agarwal, for the very nice and informative presentation. Well, now let's open the interactions, or if you have any questions to ask, especially the audience here, which are offline and online, yeah, you are really welcome. If you have any questions to put forward to our speaker, Dr. Deepsika Agarwal. Yes? Well, I don't, yes? Maybe our Dean, Dr. Ita and Dr. Yes, my colleague also. Yes. Maybe you have any, you are ENT specialist, maybe you have anything to ask about, eye problems. Well, to tell you frankly that Dr. Deepsika Agarwal, she's in MGM Eye Institute. It's one of the biggest eye institute in India. And it has got collaboration with eye institutes in the United States of America. So she has been here. Dr. Deepsika has been in Medan. She has visited some of the hospitals here, like Pringadi Hospital, our USU, and then she has also visited some of the teaching, or of the medical college, teaching institutions. So maybe we also hope, Dr. Deepsika, maybe you can visit Medan for the second time. Well, if you have any questions, come on.
Visited all the hospitals, and you are doing very good work, and few doctors also have come here for the FICO training. So really we have enjoyed, and we would like to come again there, and I welcome all of you whenever an opportunity, please come. And just my question is, in your like those ophthalmologists are there in the audience, how frequent they are seeing these ocular tuberculosis cases, and how they are managing, if any input or anything they would like to say?
Yes. Yes.
Students who are
I've also, I had the opportunity of visiting MGM Eye Institute also. I have seen it myself. It's really wonderful. It's, I think, a 10-story building with all various specialties, Dr. Deepsika. I was really very impressed. Maybe, Doctor, before we have any questions from the audience, I would like to ask you, what about the incidence and prevalence of ocular, because this is very rare. I don't know, as you just mentioned just now in your, in your presentation, that we also have ocular TB in some, like India and in Indonesia. I just saw about the percentage in your presentation. It was about 8%, if I am not mistaken, yeah? We have also ocular TB in some of the developing countries like Philippines, maybe. That's what I saw in. So, by the way, yes?
27%, and in Indonesia it is 8%, you're right. And diagnosing the patient is sometimes a difficult task, but when we diagnose on time, then the outcomes are very good. Because previous days, when there were no awareness about anybody, like few decades back, when anybody has a tuberculosis, there was a concern like how this patient is going to survive. And second one about the spread. So people used to afraid to keep the tuberculosis patient, but because of the good medicine, good diagnostic tools, now that fear is not there, and we are diagnosing early, and the immunization programs which are going on all over the world, those are also causing the prevention of this disease. So these are the important points which have improved the condition.
Oh, thank you very much, Dr. Deepsika Agarwal. Well, I would also like maybe to ask your kind self, Dr. Deepsika, you are also, you have a program for residents. You are also teaching, what do you call it, postgraduate courses, right? So suppose maybe we have also medical students here, we have GPs. If they would like to take post-graduation in your institute, is it really possible, Dr. Deepsika?
Like for the graduation to post-graduation is not like, because that is a degree. So that without the international collaboration we cannot. But who are the postgraduate, like MSMD in ophthalmology, for them we have a fellowship program, like fellowship program of 1.5 year or 2 years. In that we comprehensive ophthalmology, glaucoma, vitreoretina, all these especially. So we are getting the international candidates from different part of the world. So for that, and even for the ophthalmologists, we have a short-term training programs also. So those have completed, but no, not very good exposure in cataract surgery. So we are giving the training for the SICS, for FACO.
Yeah.
So those are facilities we are having here.
Well, I think this is a good information for our dean, maybe Dr. Leo. Maybe we'll make a MOU maybe with our university, especially our medical college, with MGM Eye Institute. Dr. Deepsika, I hope that we can have more collaboration in the future.
And we can exchange our this expertise with each other. Whatever the good you have, we can learn, and whatever we can share, that we will. So in that way, we can have a. So might be after this conference, we can have a discussion and can plan something which
Yes.
we in a form of MOU. So everybody can
Yeah.
get the benefit out of this.
Yes, thank you very much, Dr. Deepsika, for your, I mean,
Thank
nice,
you.
nice
Thank
information.
you for
Okay.
Thank you everyone for giving this good opportunity, and really it is a privilege for me to be a part of this prestigious international conference.
Okay, thank you. So, ladies and gentlemen, let me summarize that ocular TB, we have also cases of ocular tuberculosis in some of the developing countries. As we see that, as we all know that tuberculosis is caused by Mycobacterium Mycobacterium, if I'm not mistaken, what you presented, as we all know. And the spread can be through lymphatics, maybe hematogenous, as you have mentioned in your presentation. Of course, the gold standard here is that we treat ocular tuberculosis just like we treat pulmonary tuberculosis. And for diagnosis, as you have said, that we have Mantoux test, then we use X-ray, and the latest technique which you mentioned, which we are also IGRA, yeah? Yeah, IGRA, and then there's one more technique you mentioned. Yeah, that's quite interesting. And of course, this is, you have really given us good information about ocular tuberculosis, yeah? It's not only pulmonary. Of course, we had various speakers yesterday. We had tuberculosis of the spine, and then tuberculosis of the, it can also spread to the brain. in the brain matter, meninges. Yeah. So, of course, the spread is so great. Yeah. Well, Dr. Deepsika, thank you very much for your very informative presentation. Let's give applause to Dr. Deepsika. Okay. Thank you very much, MC.
Thank you very much. And nice to see you all. And again, I welcome all of you. It's an opportunity, please do visit. Thank you.
Thank you, Mrs. Deepsika Agrawal, for the informative and insightful presentation, and Mr. Surjit Singh as our moderator. Our second plenary lecture today is from Mrs. Pravina Pospanatan, who will be held by our moderator, Mr. Amran Simanjuntak. Mr. Amran Simanjuntak, time and place are yours.
Good morning. Assalamualaikum warahmatullahi wabarakatuh. Good morning everyone, the speakers, the lecturers, all the faculty. I am Amran Simanjuntak. I'm an ENT specialist, a rhinologist consultant from Haji Hospital Medan. And this time I would like to introduce my friend from Malaysia. She will talk about the chronic rhinosinusitis in Malaysia. I know her as graduated from University of North Sumatra in 2013, and I met her in Ipoh, Malaysia, when I was invited as the faculty of a workshop in Malaysia. They made a workshop of rhinology surgery, and I'm one of the faculty from Indonesia. And I met her again, and I believe she has known about experience 4 years in otolaryngology as a medical officer, not yet ENT specialist, but I believe Pravina known about the chronic rhinosinusitis in Malaysia. I believe that. And I will give the Pravina to talk now, please.
Yeah. Can you all hear me? Good morning. Okay, I will share my screen.
Okay, morning, Pravina, please.
Yeah, hi. Just 1 minute, I can't see to share my screen. Oh, yeah. All right. Thank you, Dr. Amran. He is my alumni from University Sumatra Utara. And thank you for Nommensen Health and Medical Science International Conference for inviting me as a speaker. I'm currently doing my second year residentship in National University of Malaysia under ORL. And today I'll be presenting about chronic rhinosinusitis in Malaysia according to the Clinical Practice Guidelines, CPG. Okay, so chronic rhinosinusitis in Malaysia. What is the definition of chronic sinusitis? Is the inflammation of the nasal cavity and paranasal sinuses, the etiology of which includes both infectious and allergic mechanism. So the epidemiology, the prevalence rate of CRS in Europe, US, and Brazil is about 5 to 15%. Meanwhile, in Asia, is reported in Korea, China, and Singapore as 7, 8%, and 2.7% respectively. So the rhinosinusitis can be categorized into two, that is acute, less than 12 weeks, and chronic, more than 12 weeks. What are the predisposing factors? So you have two types of predisposing factors. You have mucosal swelling and also mechanical obstructions. So mucosal swelling, you have what you call this, most common mucosal predisposing factor will be allergic rhinitis, non-allergic rhinitis like vasomotor rhinitis, aspirin sensitivity, asthma. You can see patients coming with asthma, having nasal blocks, and smoking, swimming, discongestions, and also hormonal immunologic disorders, environmental or occupational irritants and pollutants, or gastroesophageal or laryngoesophageal reflux like LPR. So mechanical obstructions, you can have anatomical abnormalities of the osteometal complex. You can have patients with deviated nasal septums having chronic rhinosinusitis, or patients with nasal polyps. And some patients, they also have defects in mucociliary clearance, trauma, foreign body, neoplasm, nasotracheal intubation, or nasogastric intubation can also precipitate to chronic rhinosinusitis. So what are the common organisms that can cause a chronic rhinosinusitis are divided into aerobes and anaerobes. So the most common when we take a swab will be a Staphylococcus aureus and Streptococcus species, and anaerobes will be bacteroids, Fusobacterium, or anaerobic cocci. So the clinical presentation as a GP, when a patient comes to you with nasal obstruction, rhinorrhea, headache, decrease of smell, for instance, is known as anosmia, post-nasal drip, facial pressure or pain, then you should also have a differential diagnosis of sinusitis, a chronic sinusitis, and it depends on the duration, whether it's less than 12 weeks or more than 12 weeks. There's also a condition acute on chronic sinusitis when patient has chronic sinusitis symptoms. At the same time, they also have fever, sore throat, cough with facial pains, post-nasal drip, and also headaches. And then we have to differential the acute, chronic, and also acute on chronic. So the other differential diagnosis of chronic rhinosinusitis are rhinitis, dental diseases, migraines, stress, temporal arthritis, intracranial forces that is causing headaches. So when a patient comes in with all the chronic rhinosinusitis symptoms, at the same time, they also have symptoms like epistaxis, loosening of the upper tooth, fullness of the cheek or palate, facial numbness, and trismus, ptosis, or any cranial nerve palsy, then you should also suspect malignancy. So clinical diagnosis. Clinical definition of the rhinosinusitis in adults are defined as the inflammation of the nose and the paranasal sinuses, characterized by 2 or more symptoms, one of which should be either nasal block, obstruction, congestion, or nasal discharge. You have anterior or posterior nasal drip, together with facial pain or pressure, reduction of or loss of smell, is hyposmia or anosmia, and at least one of the following endoscopic signs of nasal polyps, mucopurulent discharge primarily from the middle meatus, or edema or mucosal obstruction primarily in the middle meatus. So examinations, since we are only, examination at the primary level. So what you can do when the patient comes to you in your GP settings is an anterior rhinoscopy. If you don't have the pluricum, you can actually just lift the nose aperture up to view the anterior nasal condition, and you can actually see some mucosal edema, nasal inflammation, or you can see a purulent discharge. Anterior rhinoscopy has a limited value in diagnosing chronic rhinosinusitis as opposed to nasal endoscopy, which provides a better visualization, but nasal endoscopy will be done by the ORL surgeons. So this is images of the anterior rhinoscopy. So the image A is a normal nose finding, is a patent right nasal cavity, where you can actually see a little bit of your inferior turbinate, some of the septum, and also the nasal, anterior nasal aperture, which looks normal. But if you have, like, for instance, a fleshy mass which is occupying 90% of the nasal vestibule, you can actually visualize it using an anterior rhinoscopy or just beaming up the nose. So this is an endoscopic view of our our nasal endoscope. This is a gold standard in diagnosing chronic rhinosinusitis, where you use a nasal endoscope. And as you see, you can see the turbinates, you can see a nasal polyp and a purulent discharge. This is a typical clinical presentation of patient with a chronic rhinosinusitis. So from the nasal endoscope, we can see a purulent discharge and also polyps, as we see in the next, in figure 7. So there are two types of nasal endoscopes, that is rigid and flexible. I'll be focusing more on the rigid scope. So it gives you a better image and clarity and a better patient's comfort lah. But you must always explain to the patient that what type of procedure will be done and whether it feels comfortable or it feels pain, or when it feels pain, the patient have to inform the surgeon so we can decongest the nose. So in addition to if patient have been if patient presented with more than 12 weeks of history of nasal block, and we find that there is a purulent discharge, we can also take a culture and tissue sampling and enables the endoscopists to perform procedures such as nasal toileting as well. So nasal endoscopy is not required in diagnosing CRS in a primary care, as you don't have this nasal endoscope revelators. So however, it is necessary to be performed in oral settings. So these are example of how a rigid and nasal endoscope looks like. And I have a short video of how they perform a nasal endoscope. after the nasal endoscopy, what are the other tools that we can use is to see the CT changes. So you have mucosal changes within the osteomedical complex and or the sinuses. And also patient have past medical history of chronic rhinosinusitis and it is medically diagnosed. So now we will go into the management of chronic rhinosinusitis according to the Malaysian CPD clinical practice guidelines. So the chronic rhinosinusitis indication for early referral within 1 week. You have failed course of optimal medical therapy, more than 3 sinuses infections per year, suspected fungal infection, granulomatous disease or malignancy. So indication for urgent referral within 24 hours is severe pain or swelling of the sinus areas, particularly in immunocompromised patients such as uncontrolled diabetes, end-stage renal failure, patient with human immunodeficiency virus HIV. So management of CRS, you have antibiotics should not be used routinely in chronic rhinosinusitis unless it is acute on chronic rhinosinusitis. Intranasal corticosteroids should be considered for 14 to 21 days in acute rhinosinusitis. And for chronic rhinosinusitis, it should be given for 16 to 52 weeks. Short-term oral corticosteroids should only be given in chronic sinusitis at otolaryngology centers. So GPs are not advised to prescribe short-term oral corticosteroids for all patients who present with CRS. So, and antihistamines should be prescribed in rhinosinusitis as associated symptoms suggestive of allergic rhinitis, such as sneezing, nasal itchiness, nasal obstructions, and rhinorrhea. So other medication that is indicated for management of CRS is analgesics because patients come in with facial pain, headaches, and based on the severity of pain. Decongestants, the nasal mucociliary rate is significantly slower, the clearance is slower in a patient with CRS. So to improve the mucociliary clearance, we can actually give oxymetazoline after 20 minutes of spraying into the nasal cavity. You can actually feel the nose is actually cleared and decongested. So the flow of a GP to when to refer a patient with a chronic rhinosinusitis to a ENT surgeon or to continue their therapy. So when patient comes in with nasal obstruction or purulent or greenish nasal discharge, facial pains, headaches, smell disturbance in a duration of more than 12 weeks, so what we can do is an anterior rhinoscopy. That's the basic thing you can do in the GP settings. But plain X-ray is not recommended as sometimes we cannot identify the sinusitis using a plain X-ray. And what we should start is topical steroids. That is intranasal corticosteroids. That is, you can use your mometasone, you can use a fluticasone, and also nasal irrigation. So nasal irrigation, you can use alkaline douching or normal saline douching for the patients, and you re-evaluate the patients after 4 weeks. So if there is an improvement of symptoms, then you continue the therapy. And if there is no improvement, then you should refer the patient to a ORL specialist. So these are the indications of referrals of acute and the chronic. These are the I will focus more on the chronic rhinosinusitis. So in chronic rhinosinusitis, the early treatment or early referral is when fail of the course of optimal medical therapy and more than 3 sinus infections per year and suspected fungal infection or granulomatous disease or malignancy or immunodeficiency. So when you need an urgent referral, from a GP, we need an urgent referral is when you have severe pain, swelling of the sinus areas, lower threshold for immunocompromised patients like uncontrolled diabetes and stage of renal failure or HIV. You see patients coming in with nasal block, with paraorbital swelling, or you have facial cellulitis, then it's an urgent referral within 24 hours. So this is the flow of management in ORL settings. So when a GP sends a patient from primary care to an ORL specialist, what do we do in the clinic? So first, we will have history and investigations. So after history taking, so patient coming with nasal block, rhinitis, facial pains, post-nasal drips, and then we proceed with investigations. So the gold standard will be nasal endoscopy and skin pretest if indicated to know whether the patient is allergic to any allergens. And we also consider other diagnosis and predisposing factors such as bronchial asthma or smoking. So the treatment in ORL settings is topical steroids, intranasal corticosteroids, and you have nasal irrigations. And we have short-term oral corticosteroids, whether you can use prednisolone or dexamethasones. And consider oral antibiotics as immunomodulator if serum IgE is low or normal. If there is an improvement of symptoms, then we follow up the patient in the ORL settings and we continue the topical steroids, nasal irrigation, and short-term oral corticosteroids. But if there is no improvement after the treatment for about a month, and patient still comes in with patient is still symptomatic, and nasal endoscopy reveals that there is still mucoid thick pus from the OMC, then we will consider to do a CT scan of the paranasal sinuses for the patient, and also consider endoscopic sinus surgery. Post-surgery, we will also follow up the patient at the ORL setting, and we will continue the topical steroids, nasal irrigation, and short-term oral corticosteroids. So one of the surgical interventions for chronic rhinosinusitis, if failed treatment, failed medical therapy, will be functional endoscopic sinus surgery. It's the most common surgical treatment. It is minimally invasive technique that uses the endoscope to enlarge the drainage pathways, resulting in improvement of the ventilation and restoration of nasal cavity and paranasal sinuses physiological functions. Okay, thank you.
Thank you very much, Pravina. I'll give the floor if there is any questions, please. Pravina talk about where is the positions of general practitioners in managing the chronic rhinosinusitis. I think it's not very different in Malaysia or in Indonesia how to manage this disease. As general practitioners, I think you have many questions how to manage the chronic rhinosinusitis in Malaysia or even in Indonesia. Please, for the participant, give the ask. Okay, please, Doctor.
Good morning, Miss Pravina. I know you doctor from USU, ya?
Yes.
Your friend, Dr. Dina, is here now.
I can't hear you.
Dr. Dina.
Oh yeah, hi Dina. How are you?
Where are you, Dina? Dr. Dina.
Yes, hi.
Dr. Pravina. Okay. Thank you before. I want to know about epidemiology of chronic sinusitis in Malaysia. Could you tell me us? Thank you.
So the epidemiology in Malaysia is about 20% of the patients that we have done a research under the clinical practice guidelines is about 20% from the research that we have done here. So every patient that comes in does not present with acute. Chronic has higher, higher prevalences actually, about 20%.
Thank you, Mr. Amrat.
Dr. Pravina, I have a question. From all the patients that you have cured this chronic running sinusitis, how many of them will be cured successfully or fail of therapy? So you have to give it to
For
you.
instance, we take in like walk-in clinic patients, about 10 per day. About 8 can be cured medically, but there will be, the symptoms has improved, but maybe about 3 patients that we had to proceed with CT scans and also a functional endoscopic sinus surgery FAS.
Okay.
And these kind of patients are usually more immunocompromised patients. Maybe they are diabetic, or they have some very rarely we get HIV patients with chronic sinusitis, because most of them come with acute fungal infections actually.
If you see the patient with fungal sinusitis, do you still cure it with medical therapy or straight to the ENT specialist to be operated?
ENT specialist to be operated is an urgent, it comes under urgent referral and urgent surgery if it is an invasive fungal sinusitis.
Okay. You make a diagnosis fungal sinusitis with CT scan or only the nasal endoscopic?
Usually it is, we can, invasive fungal sinusitis, we can actually diagnose using an endoscope. You see the condition of the nasal and also the erosion that it has caused. And if you want to know further damage of the sinuses that has been done, then we can proceed for CT before surgery, or we can go in straight for FAS.
Okay. Another question. You are as a medical officer in Hospital Raja Bainun, as general practitioners or the ENT assistant? You are as a GP or you are as a part of ENT department to cure this patient?
I'm part of the ENT department doing my second year registrar in National University of Malaysia.
Yeah. Congratulations.
Thank you.
At the floor, do you have questions, please? Dr. Surjit Singh, she is my friend, my teacher.
Yes, I think our presenter, our speaker, maybe she was our student, yeah?
Yeah, I think
because we were lecturers in USU.
Yeah.
Until now, we are still teaching, yeah, Dr. Rita, residents from USU. Yeah. I think you still remember me. Yes, from the forensic department,
Forensic department, yeah, right.
Yes, I remember you.
Well, it's really great to see that you have become a ENT specialist.
Yes.
So this is, I think, by the support, by the spirits given by Dr. Rahman, Is it Dr. Amran? Sorry, Doctor. I remember Dr. Abdurrahman, Professor
Abdurrahman.
Professor Abdurrahman. He was my teacher, and
Yeah.
Well, I think I'm really interested about this presentation. We have a lot of cases of acute or rhinosinusitis, as you said. Well, I'm just curious to know that you mentioned that the etiology, talking about the etiology, we have bacterial, right?
Right.
Aerobic and anaerobic, and then we have fungal. But how do we diagnose? How do we know it's fungal? Do we need a culture? Right? So patients come, you know, what should I have to, for general, I mean talking for GPs, yeah? But not for, for you, Amran, you can put that
Yes.
fast, you know, you can do it, yeah? Okay, so like how do I mean these GPs, no, how do they diagnose that it's due to fungal? Because it's drug resistant, you keep on giving antibiotic, you keep on giving high doses, yeah, so it won't respond, yeah, Dr. Amran, right? So, well, what do you suggest? Any gold standard in diagnosing, in making the diagnosis? And then second, in my experience about FAST, you know, surgery, usually patients come again, they have the same problems. It's a relapse, you know. What is the real, you know, maybe you must be more experienced, so I see patients, oh yes, I had FAST, I mean, what do you call it, endoscopic surgery, but sometimes they do come and they again start having the symptoms like this nasal discharge, sneezing, and malar pain, and so on. Thank you very much.
Okay, for your first question about the fungal sinusitis, so how do we actually diagnose the patient at the GP settings? Is recurrent same symptoms of the patient coming in. At the same time, fungal sinusitis, when you see if it is invasive fungal sinusitis, its progression is very fast. So patients can come with severe headaches or mental altered status, or they can have like a dark ulcers from the nasal cavity or the palate. Then they have to refer the patient as soon as possible to an ENT surgeon to rule out fungal sinusitis, because the chronic rhinosinusitis is actually not, it doesn't progress as fast like a invasive fungal sinusitis. And some patients will also have visual disturbance, and then we have to refer as an urgent referral. So for your second patient, even though patient has undergone FAST and then they come in with nasal discharge and rhinitis symptoms with the post-nasal, they most probably it is a chronic rhinosinusitis patients post surgery, but they also still have some allergic rhinitis, which they are also still allergic to dust mites or any seafood that can cause rhinitis as well. Did I answer your questions, or shall I give it to Dr. Amran to?
Yeah, Dr. Amran is also an expert, yeah. Or Dr. Rita is here.
Yes,
Yeah, maybe you might want to add as a, yes, ENT specialist. Come on, Dr. Rita. Sharing your experience also. Well, I think that's good, very, very clear, yeah. Dr. Amran, very good, I mean.
Okay.
And then one more, last question. Usually we do a nasal rinse, yeah? We have a bottle. We can use sodium chloride or maybe, what do you call it? It's incessant, yeah? Cleansing. So we can use it, we advise the patients, yeah? Well, how often? I mean, in acute, or can we also suggest in chronic rhinosinusitis?
Any patient with a sinusitis can actually use alkaline bleaching. It's just to clear off your mucosal crustings or thick mucoid discharge. So it clears the nose, and it it gives a better aeration, and when they use the nasal spray, it is more effective post-douching the nose. So we can actually use the douching for 3 times per day or 4 times per day according to the patient's nasal condition. Some patients, they prefer to use only twice a day. So it depends on the patient's symptoms and how often they want to use. But usually post-surgery, we advise the patient to use at least 3 times per day.
Okay, thank you very much.
Thank you, Dr.
It's clear
Sujit.
enough.
I will add some information. I've been as a consultant of rhinology for about 7 years, and nowadays I take care of about 10% to 20% patients comes again with after operation. So I do the surgical revision. So the problem is surgical revision needs proper tools, proper instrument, and not all the hospital in our city can prepare that instrument to give the surgical revision. So we still have any challenge in this facility, or challenge in this how to manage the chronic rhinosinusitis after operation. Sometimes I take the patient after 4 fast surgery and I am the 5th people, or sometimes I'm the 4th people. He can take the fast from Medan or Penang or whatever. He comes to me, I have to do the revision surgery for the 5th time, and it is not easy to do the revision surgery. It depends on our competency and our facility. And it is not easy in our city to prepare a good facility for that case. So some case, actually the revision case is always not easy. I have to take it to special hospital who prepare the good instrument for the revision. And meanwhile, if not revision, only sinusitis, it's not easy. Some other factors as allergy or others make the disease recurrent. I think that's. I think Dr. Pravina, thank you very much for your presentation, a very good presentation. Thank you for everyone here. I give to the moderator. I give to the.
Thank you so much, Dr. Amran, and also the conference for giving me the opportunity to speak today. Thanks.
Thank you, Mrs. Pravina Pospanatan, for the informative and insightful presentation and discussion, and for Mr. Amran Simanjuntak as our moderator. Our last plenary lecture is from Mr. Thomas Hui, who will be held by our moderator, Mr. Terang Meriala. Mr. Terang Meriala, time and place are yours.
Thank you, Master of Ceremony, Dr. Christine. Good morning, offline and online participants. We already has distinguished speaker from India and Malaysia. Now we will continue to the next plenary lecture. This time we have a very distinguished speaker from USA, California, with the distinguished Dr. Thomas Hui. He will share knowledge and expertise about pediatric acute appendicitis. This lecture will take 30 minutes with 10 minutes Q&A. We will say good night in USA, Dr. Hui. Okay. We are very honored, Doctor, to have you join us in the second NoHMSIC 2023. Dr. Thomas Hui is an expert in many experiences. I would like to gently remind our operator to share Thomas Hui curriculum vitae on the screen, please. I will read the curriculum vitae of Dr. Thomas Hui. Dr. Thomas Hui, MD, FICS, FRCS consultant, FIAP, and he had academic history 1989 from University of British Columbia, Vancouver, Canada, and get medical doctor in 1993 from University British of Columbia. He also have residency and fellowship training Intern General Rotating Royal Columbian Hospital, New Westminster, Canada, and thus in 2005 Fellow Pediatric Surgery, Montreal Children of Hospital, McGill University, Montreal, Canada. Also have a board certificate, has a Royal College position and Surgeon of Canada General Surgery in 2005, Royal College of Physicians and Surgeon of Canada Pediatric General Surgery in 2005, American Board of Surgery General Surgery 2013, and American Board of Surgery Pediatric General Surgery 2014. And now he served as at the Stanford University, USA, one of the best universities of the world, from 2023 as a clinical associate professor. Dr. Thomas Hui also have many awards. We can see in the curriculum vitae. In 2012 until 2022, he has top doctors. And also in 2014 until 2022, San Francisco Magazine Top Doctors Pediatric Surgery. He also published 47 reviewer, 15 abstract, and 2 book chapter. And now is Dr. Thomas Hui already connected? Okay. We'll give the time to Professor Thomas Hui. Time is yours.
Can you hear me? Can you see my slide?
Yes. Good morning, Dr. Thomas Hui.
Yeah. Are you able to see my slide and hear me?
Yes, I am able to see your slide.
Oh, great, thank you.
But I'm sorry, your screen sharing is being, the slide is still stopped, Dr. Thomas Hui.
Still cannot see me, right? Because
No. Let's keep this. Hello, Dr. Thomas Hui.
yeah.
We already have your slide.
You have my slide?
Can we use our slide to this presentation?
Can you? Yeah, I guess you should be able to do it again. I can't share my slide online.
Yeah. How about we use your PowerPoint that we have now?
You can see me though, right?
Yes, we still can see you.
But how come when I share, I can't share? The screen share is paused. Let me see. Yeah, I can't. I don't know why I can't share my slide.
How about if we use the PowerPoint that you sent to us?
Yeah, I sent you a PDF.
Yes,
I think I
okay.
sent you.
Dr. Thomas Wee, the slide is already on the slide.
Okay.
Okay, thank you.
Let's see here.
Time is yours.
I can. Okay, good morning, everybody. My name is Dr. Huey. I'm actually a pediatric surgeon. Belong to the Faculty of Medicine at Stanford University. I want to thank the organizing committee to invite me for this international meeting. My topic today is pediatric acute appendicitis. Next slide. Yeah, I'm not able to see your slide. But anyway, are you able to see the next slide? Let's see. So acute appendicitis is one of the most common conditions that in children with abdominal pain that require hospitalization and, oh, here you go. Okay, great. Require hospitalization and a surgery. About a third of all pediatric admissions for abdominal pain is secondary to acute appendicitis. The incidence of appendicitis is more common in boys or men than girls or women. Let's see here. And well, lifetime risk about 8.7% in men and 5% in females. It very rarely occurs in children younger than 5 years of age. And at that young age, it has a high incidence of perforation due to delayed atypical presentation. Next slide, please. Appendix is a blind ending structure, so obstruction from any reasons can cause appendicitis. The most common reason for obstruction of the appendix in a child is actually fecalith or lymphohyperplasia. Next slide. These are the symptoms of acute appendicitis and the physical examination signs. The left basically detail the common symptoms. Abdominal pain, migration of pain to the right lower quadrant, fever, nausea, and vomiting. On the right are the physical examination. Tenderness over the McBurney's point is a classic sign. Rothsing, Bloomberg, psoas, obturative signs are all signs indicating a localized peritoneal irritation from the appendix inflammation. Pain with ambulation or jumping are fairly common sign also. Next slide. These are the differential diagnoses of acute appendicitis. The most common is mesenteric adenitis. Depending on age and sex of the gender of the patient, in female patient during puberty, one has to also worry about ectopic pregnancy, ovarian cysts, Mittelschmerz, and even pelvic inflammatory disease, PID. At times, a viral like strep or even viral pharyngitis and also pneumonia can actually present with abdominal pain and can be mistaken as appendicitis. Next slide. In diagnosing acute appendicitis, our approach is to first use something called a pediatric appendicitis score. There are a variety of scoring systems available, but the pediatric appendicitis score we felt is the most accurate for children. So what is a pediatric appendicitis score? It's basically made up of 8 elements. And out of the 8 elements, 6 of them are derived from history and physical examination. As you can see on this slide, the last 2 items are labs, are CBC, basically leukocytosis, with a white blood cell count more than 10,000, and the left shift with an ANC more than 7,500. So this is a very useful scoring system, and the total score is 10. And how do you use this system? It's very simple. You basically put all the elements together, you calculate the score. Any score less than 3 means a low likelihood of appendicitis. Anything above 8 is a high likelihood of appendicitis. Anything in the middle is useless. It means nothing in terms of predicting whether the patient abdominal pain is from appendicitis. Next slide. So this score has undergone multiple prospective studies, and it's basically from all the studies done, with thousands and thousands of kids with abdominal pain, if anyone score less than 3, it has a 0 to 2% chance of having appendicitis. If anybody score more than 7, it has a 78 to 96% chance of appendicitis. Anything in the middle doesn't really predict whether the patient has appendicitis or not. So standalone, this test is not sensitive or specific enough to use as the only modality for diagnosing or ruling out acute appendicitis. However, it is very useful to stratify a patient into different risk categories so that the primary care physician or even the surgeon can take the next step. Next slide, please. What about imaging studies? Abdominal X-ray is not useful in diagnosing appendicitis. It is useful to see if the patient has a small bowel obstruction or not, and the number one reason why a child would have small bowel obstruction is appendicitis, most likely complicated or perforated. Ultrasound is the preferred method of imaging study in USA, in children, to diagnose children with acute appendicitis. It has an advantage that is safe, non-invasive, and does not involve any radiation. It's quoted that it has a high sensitivity, 78 to 94%, and a high specificity, 89 to 98% in all major studies. But one caution that one has to understand is that these studies are done in major children's hospitals, i.e. the ultrasound are performed by sonographers who do nothing but doing ultrasound on kids to rule out appendicitis. So this may not apply to some hospital or some setting whereby the sonographer may not be as familiar with doing the exams on children. So that is something that is very important to keep in mind. Also, the ultrasound accuracy is much less when the child is more obese, or when the child is bigger, like when they're like older teenage years, when they're more like an adult-sized person. It is also much less accurate when someone do an ultrasound on a child who has very low clinical suspicion of appendicitis, and that's been proven in studies. What that means is that if you have a very low PAS score and you choose to do an ultrasound, it's very likely that ultrasound can be false positive or false negative, and it can actually lead you down the wrong path. Next slide. CT scan is not so commonly used anymore because of the risk of radiation to young children. It does have a very high specificity and sensitivity. It's probably the most accurate test, together with MRI. Some hospitals here in the US have been using MRI actually to diagnose appendicitis. Very rarely, because it's very rarely available, the MRI, but it's very accurate if you have it. And it has the advantage of not having any radiation. Next slide. So basically, one of the most important things that I always tell my emergency room doctors or pediatricians that never order an ultrasound as a screening test for pediatric abdominal pain looking for appendicitis. It is very common that in the primary care setting or even in emergency room setting that every kid who show up with abdominal pain for some reason is appendicitis until proven otherwise. And it's very important to use the PAS score as a guide. If the patient has very low score, do not order an ultrasound because that has very low accuracy. Next slide. So this is the summary of the pathway of how you work up a child with suspected appendicitis. You do a detailed history and physical, you obtain labs, the minimum is a CBC. You calculate the PAS score. If the score is low, less than 3, low suspicion, you basically oral challenge the child in your clinic or in the ED, and then you re-examine him or her. And then if the patient's pain go away or get better, you can counsel the parents. The kid can go home, and if the pain get worse or persist, then come back. If the patient continues that pain, is not getting better, or even frankly vomiting, then they need to be admitted and observed. If the score is very high, 8 to 10, you don't need to do anything else. You call your surgeon, and the surgeon can decide if he or she wants another imaging. Sometimes we do, because sometimes we suspect the patient might be perforated with an abscess, and we want to prove that with the imaging, and treatment is not surgery necessarily. It could be IR drainage of the abscess. If it's between 4 to 7, the PA score is equivocal, we recommend imaging. This is where imaging helps, and ultrasound is a good test if you have sonographer that can perform ultrasound with reasonable accuracy in children that to grow appendicitis. Otherwise, MRI or CT scan, depending on the patient, how thick the patient is, etc. And a surgical consult can be obtained after the imaging is performed. And if the patient continues their pain, pretty severe abdominal pain and tenderness, then the patient should be admitted and observed. Next. It's important to remember that the younger the patient is, the more likely that if they have appendicitis, will be perforated, and their symptom will be very atypical. So i.e., you're not going to get the right low quadrant tenderness that everybody thinks appendicitis should have. They could have come in with just diffuse peritonitis. And this is the statistics. Like any young children less than 5 is like 51 to 100% chance if they have appendicitis already perforated. Next. So what do we do once we diagnose a patient with acute appendicitis? Well, we immediately start an IV and hydrate them. And second thing we do is start them on IV antibiotics. It is acceptable to pick one of 5 options that I listed in this slide in terms of antibiotics. It's also important to know that one should also give a dose of antibiotics within 1 hour of surgery. Now that's not usually the concern from the primary care or from the ED doctor. Usually that's something the surgeon have to order. Why is that important? Because sometimes we admit patients that the diagnosis is made in the ED or by the primary care physician. So they send a patient to ED, or the patient may be already in the ED and they start antibiotics. The surgery may not happen until several hours later, depending on the availability of the OR or the surgeon. And at that time, the antibiotics need to be redosed. But that is really the responsibility of the surgeon. And finally, surgery. Laparoscopic approach is preferred over open. That's from several studies showing that laparoscopic approach is associated with the decreased length of the hospital stay, decreased wound infection rate, and also earlier resumption of normal activities. So almost all appendectomy done in our area are done laparoscopically, regardless of the child's age. Next slide. Timing of surgery. It used to be that when I went to medical school many years ago, that acute appendicitis is considered a surgical emergency, i.e. once it's diagnosed, the surgeon is called right away and something is expected to be done surgically. It's actually not true anymore. And there's a study to prove this. One big study basically showed that there is no increase in postoperative complication observed if surgery is performed within 24 hours of diagnosis. So that is acceptable. Now, obviously, if you diagnose appendicitis and you choose to operate 24 hours later, the length of stay will be longer, although it's not translated into increase in infectious complications. However, if you increase the length from the time from diagnosis to surgery to more than 48 hours, that has been shown to increase the risk of surgical site infection and 30 days adverse events. So is it acceptable to not operate on a patient with appendicitis? The answer is yes. One scenario is that if a patient presents with more than 7 days of symptoms, sometimes 10, 15 days, and they show up because they're just the pain or whatever they have, fever, nausea, just not getting better. But if you examine them, they are relatively well, i.e. they are not vomiting, they're not dehydrated, and they have localized tenderness, but no peritonitis. So a lot of these patients, what happens is that their body is basically walling off the appendicitis and containing it. And these patients can actually be treated non-operatively with antibiotics and cool down the entire inflammatory process and wait 6 to 8 weeks later and do an interval appendectomy. Obviously, while the patient is being treated non-operatively with antibiotics in the hospital, if they don't get better or if they get worse, they then need emergency surgery. Next. So the classic or the most popular operation, at least in the United States, for surgical treatment of pediatric acute appendicitis, laparoscopic, the typical 3 trocars technique as seen in this slide here. The left show the location of the 3 trocars, and the right is a laparoscopic view of appendix that's inflamed. Next. In our practice, we have adopted the single incision laparoscopic surgery, whereby the entire laparoscopic operation is done through 1 incision at the belly button. The belly button, or the umbilicus, is a natural scar, so you use that to advantage when you do the operation this way. You basically don't really have any visible scar except for the umbilicus, and the outcomes is as good as a 3 trocars laparoscopic approach. Next. Postoperative management of acute appendicitis. Uncomplicated or simple appendicitis, no antibiotics needed after surgery. Most patients, almost 99.999% of them, are discharged home less than 24 hours post-op. And we have a pathway to discharge some of these patients from our recovery room within 2 or 3 hours after surgery, even. That is possible. And for complicated appendicitis, obviously they don't go home in 24 hours. The antibiotics are continued, IV antibiotics are continued until the 4 criteria are met. Afebrile for more than 24 hours, able to tolerate a regular diet without nausea or emesis, pain well controlled on oral analgesics. If they're still requiring narcotics or Toradol or things like that, then no, they cannot go home. A benign abdominal examination. Next. Discharge criteria, very similar to the criteria for terminating antibiotics. Some surgeons also use a normal white blood cell count as a criteria. Not everyone use that. The total length of antibiotics course is controversial, because in not long ago, we as in our national organization, the American Pediatric Association, recommend that any child who has perforated appendicitis or complicated appendicitis have a minimum of 5 days of IV antibiotics. That means they'll stay in the hospital for 5 days. But that has been challenged with recent studies saying that in some selected patients, it is okay for them to go home sooner, like 3 days without even extra antibiotics. Some surgeons will discharge these patients with 2 or 3 more days of antibiotics by mouth at home. But the total length of time that they are on antibiotics, IV and PO, is a bit of a controversy. Next. Non-operative treatment of simple appendicitis. Previously, I talked about non-operative treatment for complicated appendicitis, very complicated, like patient who's had symptom for 7-10 days, they're perforated, they have an abscess, they have phlegmon on imaging. Now, in recent years, there are studies showing that antibiotics alone may be enough to treat some simple appendicitis. We don't really know if that's true, because we don't actually currently have a randomized controlled trial that's big enough to tell us one way or the other. It is ongoing. So the current recommendation from us is that in children who can verbally describe their symptom, not like 1 or 2 year old, and who have uncomplicated acute appendicitis, if they have comorbidities that make them a poor candidate for appendectomy, then they can be offered non-operative treatment. Or if the parents want non-operative treatment, sometimes the parents are very educated and they Google like the treatment of appendicitis and this come up, and we sometimes get asked like, can their child be treated non-operatively? And we sometimes do that after they are told all the risks and benefits of such treatment approach. Next. So, but not everybody with simple appendicitis can be treated with non-operative approach. There are some exclusion criteria. These are abdominal pain more than 48 hours, white blood cell count more than 18,000, increased C-reactive protein, peritoneal signs on examination, imaging findings suggestive of perforated appendicitis. These are all exclusion criteria for non-operative treatment of simple appendicitis. Why? Because all these signs indicate that it's likely the patient has perforated or complicated appendicitis. So in one large non-randomized prospective multi-center trial involving thousands of patients, that only 20% of their patients actually with acute appendicitis met the above inclusion criteria. And out of those patients, 18% still needed an appendectomy within 14 days of treatment because of failure of the non-operative treatment approach. And about a third of them needed appendectomy within a year. But surprisingly, nobody actually have any serious complication from the non-operative approach. Next. Outcomes of laparoscopic appendectomy for acute appendicitis are generally very good. For uncomplicated appendicitis, the wound infection rate is quoted about 2%. My own experience is even less than that. Intra-abdominal abscess rate is quoted about 1.4%. Again, in my own experience, is almost zero. Most patients go home within 24 hours of surgery. For complicated appendicitis, the complication rate vary, but it's much higher than the uncomplicated appendicitis. In one study, up to 55% of patients may have some kind of infectious complication, small bowel obstruction, or readmission to the hospital after discharge. Next. This is an example of an early complication. After a laparoscopic appendectomy, you can see wound infection could be very subtle, just redness and some drainage. And sometimes they would describe more pain to that area of the incision. And almost 100% of these can be treated without surgery with just antibiotics. Next. So another common early complication after laparoscopic appendectomy, almost exclusively occurring in perforated or complicated appendicitis, are abscess. These are two patients, left and right. Both had a CT scan done on post-op day 7. The one on the right was a patient that's been doing well for 5 days, but on post-op day 5 was suddenly having pain, and she couldn't even walk. She was so much pain. So we scanned her. She didn't have any fever, or she didn't have any significant nausea, vomiting, just pain. And then we can see that she has an abscess in the right lower quadrant, and that was drained with interventional radiology, and she immediately got better and was able to be discharged home in 24 to 48 hours after the drainage. On the left, you can see the multiple locular collection, also at post-op day 7. Now, this patient was different. He was actually doing well with no fever, eating, no pain. But on post-op day 5, he was noted to have swelling and redness at the umbilical incision. So the pediatrician decided to do an ultrasound. The ultrasound did not show any wound abscess, but it did show a large number of fluid collection in the abdomen, suggestive of intra-abdominal abscess. So a CT scan was then recommended at post-op day 7 to look at the extent of the fluid collection. And you can see on that scan, there's even more abscess of fluid collection than on the right side. But when they asked me, do I want to do anything about this? And I said, no, because the patient did not have any symptoms. He was eating fine, no pain, and his white count was about the same as when he first came in. So we continued antibiotics on him. And he was able to go home 2 days later on antibiotics for a total of 10 days, and he never came back for any surgery or drainage or anything like that. So my point is that when you decide to scan someone's abdomen for an abscess, it's better if the patient have some significant symptoms beyond a fever or redness in the wound. Like, they should have more pain, they should have vomiting, etc. And then when you scan them and you see fluid collection, then those fluid collection likely are contributing to the worsening in the symptoms. Another thing is that if you scan these patients too early, like within the first 5 days, you're going to find fluid collection. Therefore, are they really symptomatic? Are they really causing any problem? Like, we don't know. But in USA, we tend to be very aggressive. So anybody who see a collection anywhere, they felt obliged to do something about it, like a surgical drainage or interventional radiology drainage. Next. The second most common complication, usually also again in patients with complicated appendicitis and peritonitis, is intestinal dysfunction. Sometimes you will see a patient who cannot tolerate any feeding for a significant prolonged period of time after surgery, like more than 5 days, sometimes even. It's usually because of peritonitis and paralytic ileus. Sometimes it's constipation, sometimes it's small bowel obstruction, although that's very rare. And even in the susception, which is also very rare. One of the things that we can do to prevent paralytic ileus or even constipation is to avoid the use of narcotic for pain management and also to do early ambulation. Some of these patients may need a TPN for nutritional support if they're NPO for more than 2 to 3 days after surgery. Next. This is an example of late complications, which is very rare after laparoscopic appendectomy, but again, more common in complicated appendicitis. Small bowel obstruction is one, usually due to adhesion. It's very rare after laparoscopic appendectomy, less than 1%. You can see on the picture on the left is actually an X-ray of a high-grade bowel obstruction. On the right, you don't really see very well, but if you actually zoom in like 100 times magnification, you can see a staple, a loose staple causing adhesion between the bowel loops, causing a bowel obstruction. In I don't know about Indonesia, but in USA, a lot of surgeons use endoscopic stapler for the appendectomy. And when you staple the appendix, there will be loose staples kind of like spill over in the abdominal cavity. If you don't carefully remove every single one of them, some of these staples can cause significant adhesions, and some of these adhesion can be quite bad and symptomatic and will need reoperation. Another potential complication, although I've only seen it once, is a stump appendicitis. Stump appendicitis means that you actually left some appendix behind, and therefore, in the future, that part can get obstructed again and cause appendicitis. So why would a surgeon leave a little bit of appendix behind? It's because in complicated appendicitis, the body is trying to wall off the inflamed peripheral appendix. So it form a wall around the cecum of the appendix. So when you go in, you think you've reached the end of the appendix. You haven't. You basically, the inflammatory process has walled off that part of the appendix with the cecum, and you just haven't reached the end. So it's very important, as a surgeon, that when we do the surgery, we carefully identify all the structures and make sure we reach the end of the appendix. Next. So we all know that not all complicated appendicitis are the same. Why do we know that? Because I get asked that by my students and by my pediatrician all the time. Because they say 3 days ago I did a complicated appendicitis. You went home in 3 days. Now like a week later, I did another complicated appendicitis. He stayed 2 weeks. So why is that? Well, this paper answered that question. It's published in JAMA Surgery in 2018. The main author is Dr. Sean Rangel. He's a peds surgeon at Boston Children's and Harvard. So what he did was very interesting. He said, okay, there's a prospective quality improvement project in America. It involved, I think by now, over 100 children's hospitals. They prospectively collect data on all kind of surgery in kids. They have an equivalent program in adults. So what they did is they collect all these data on kids who had appendicitis. And his study was done between January 1st, 2013 to December 31st, 2014, with 2 years. So what he did was he looked at all the patients that was collected out of like all those hospitals prospectively, and he looked at the op report of every single one of his patients. In the op report, he found that in complicated appendicitis patient, there's always 4 findings that a surgeon consistently will put down. Next. And these 4 findings are 1, intra-abdominal abscess, 2, diffuse fibroprillant exudate involving more than 2 quadrants of the abdomen and pelvis. If you can imagine, abdominal cavity is divided into 5 quadrants, right? The left and right, upper and lower quadrants, and the pelvis. So, and then the third thing is the fecalith outside of the appendix, not inside. So this perforated, you find a piece of stool outside the appendix. A visible hole in the appendix. These 4 findings are consistently written by the surgeon of different patients. So what he said is that in some report, a surgeon will notice all 4 things present in the same patient. In other report, there will be only 1 thing, or 2 things, or 3 things. So what he said is, okay, like let's divide up the patient. Patient only have 1 finding versus 2 findings versus 4 findings, and a different combination of these findings. Do they have any correlation with the postoperative complication? What are the complications he looked at? Surgical site infection, hospital readmission or revisit, hospital length of stay, and hospital cost. Next slide. So these are the findings. Basically, the left is an intra-abdominal abscess. You go in, and the abscess is walled off by bowel or by omentum or by the abdominal wall. On the right is E, means diffuse fibropilin exudate. There's pus, there's peritoneal peel, like inflammatory peels, involving more than 2 quadrants of the abdominal cavity. Next. A visible hole in the appendix. Sometimes, you see all the inflammation, the peritonitis, and the appendix is inflamed, but there's no physical hole because the hole has healed. So one of the findings the surgeon sometimes dictates that there's a physical hole in the appendix. The last one is the fecal lift outside the appendix. You can see a little stool ball outside the bowel, outside the appendix. Next. So these are the graph of the complications. The one on the left is infectious complication or surgical site infection. The right is hospital revisit rate. You can see that on the x-axis, it talks about like F, G, F and G, F and E actually. F is the fecal lift outside the appendix. E is the more than 2 quadrant fibrofibrillin purulent exudate. And then you have HF means the patient has 2 findings, a hole in the appendix and also a fecal lift outside of the appendix, etc. So if you look at the last item on the right, you can see that these are patients with all 4 findings.
I'm sorry,
And
Dr.
with
Thomas
all-
Hui.
Yeah.
Is still many slides. We only have 2 more minutes.
Yeah, I'm actually going to finish.
Okay,
Can
thank
you
you.
go next slide? I'm going to show you the summary on the slide. Next slide. Next slide. So this is a summary of the last slide. So basically show, patient with 1 finding, surgical infection rate is about 8 to 12%, and with more than 3 findings, 20 to 28%. You can see that hospital revisit rate, 1 finding, 8 to 14%, more than 3 findings, 14 to 23%. Length of stay, much longer. The cost of hospitalization is much longer the more findings they have. So this is explain why complicated appendicitis is not a single disease. It's actually a wide spectrum of disease requiring different resources, different treatment, and different outcome. And that's my last slide. Thank you.
Thank you. Thank you, Dr. Thomas Hui, for your insightful presentation about pediatric acute appendicitis. Now we will open Q&A session. First, we will give a chance to all audience. Please raise your hand and give your name and from where institution. Okay. In the right, please, the mic, please.
Morning, Prof. Thomas Hui. Thank you very much for your insightful and comprehensive presentation. I have one question. You said that the severe or complicated acute or appendicitis, you prefer the laparoscopic technique compared to open abdominal wall. So my question is, do you have any experience during the laparoscopic technique? Then you encounter any difficulties, and then you go to the open laparotomy at last. Thank you very much.
Yeah, so the question is, do you convert from laparoscopic to open? The answer is, yeah. I mean, if you basically get into trouble laparoscopically, then you just have to do the safest thing for the child. Although in the past 10 years, I've never converted laparoscopic to open. You have to understand that the really, really bad appendicitis with a lot of abscess, inflammation, everything stuck case is very rare. And also, in those patients, they usually have symptoms that lasted more than 7 or 10 days before coming in to see us. And a lot of those patients, their body has kind of the body's not naive to an intra-abdominal infection. So, you know, the body's trying to fight it and try to ward it off. And they don't have, a lot of them don't have frank peritonitis for 10 days. So the body's walling them off, and that's why they're not coming to us soon enough. And in those patients, you know, you just have to give antibiotics and they get better. You don't need to operate. So, and then you wait 6 to 8 weeks, the inflammation all calm down. So when you go into the abdomen, it's no longer angry and everything's stuck kind of scenario. So to answer your question is yes, if you cannot safely, you know, perform the operation, or after half an hour of the operation, you're getting nowhere. Like as a surgeon, you know, like a laparoscopic appendectomy should not last more than an hour. So if 45 minutes into it, you know, and you still haven't seen the appendix, then I would say that you're in a bit of a trouble. And then, you know, then if you felt that you should open, then I think you should. And that's the answer.
Okay, thank you. Is there any from the left side? Mike, please.
Thank you. Thank you, Prof. Thomas Hui, for your interesting presentation. I want to know what things or conditions that can make the children can get appendicitis. Thank you.
Organ, like the gallbladder. So anytime a blind-ended organ get obstructed, you know, that basically then the pressure within the lumen increase, and it causes mucosal ischemia, and also translocation of bacteria and infection. That's how you get appendicitis, and in the same token, that's how you get cholecystitis. Gallbladder is obstructed by stones, and in terms of the appendix, it's also by stone. Some patients get obstructed by a piece of stool that's hardened. It's called fecalith. Others get obstructed by the lymphoid hyperplasia because there's a high amount or large amount of lymphoid tissue in the wall of the appendix and the cecum in that area. So anytime, you know, a child gets sick with a virus, you know, those lymph nodes can swell and it causes obstruction to the appendix. I would say those are the two most common reasons why a child has appendicitis. On my slide, I list other reasons like parasites and also like tumor, we're very rare, like carcinoid tumor. Again, they cause obstruction of the appendix. And I think that they all have a common pathway of causing appendicitis, which is obstruction.
Thank you. Thank you.
Well, moderator, I have one question to Professor Lee. Yeah? Well, as what we have experienced here, talking about adult or adolescent appendicitis, well, there's a correlation of diet. You know, like in Indonesia, I'm talking about Indonesia, usually adults, we consume a lot of chilies. The chili seed, it gets stuck up in the, you know, blind appendix. And then sometimes we are also fond of eating, we call it jambu, guava. Yeah, the seed also gets impacted. So that can be a predisposition to appendicitis. But in children, sometimes it's quite confusing. What is your comment? Talking about etiology of acute appendicitis in adults and children. And second point, maybe sometimes to diagnose appendicitis in children because it's very difficult for the children to communicate. You cannot ask, you know, the regional pain, not like adults. They can say, I've got pain in the right lower quadrant. But for children, you know, what do you do? Well, I think like if you press the abdomen right lower, they cry or something. You have any, I mean, do you go for investigation like you just mentioned in your presentation about ultrasonography or something like that? Thank you, Professor Lee.
I'm sorry, is the question for me? Or?
Yes, Dr. Thomas Wee. The question is for you from Dr. Thomas Wee.
I know that in some area of US, they have a high incidence of appendicitis. Those are usually in the desert area. And we felt that that may be related to lack of hydration, which may make it more likely for the stool to form a fecalith and obstruct. In terms of, you know, whether the seeds from those food can obstruct, I guess the pathology may be able to tell you, like when they look at appendix and they look at that fecalith, what is it made of? But I have not seen that in where I practice. In terms of how do you diagnose appendicitis in a child who's very young and therefore cannot tell you what symptom they have? That's completely true. Like, because in younger kids, that's why they perforate, because they can't tell their parents, like, you know, what is going on. And also, you gotta remember that, you know, children have abdominal pain a lot. It's kind of like we have headaches. Adults have headaches. We don't, every time we have a headache, we don't go and get an MRI to make sure we don't have a brain tumor. Just like when a child has abdominal pain and goes to the parents, they say, well, it's probably nothing, because it was nothing 3 days ago. And they keep waiting and waiting until they get sicker and sicker to the point where they're throwing up and they're dehydrated, and then they come to see us. So you're right. So if they cannot reliably give you a history, how do you diagnose it? It's much harder on that PAS score. Then you rely more on imaging. And ultrasound is still the way to go in major children's hospital that does a lot of ultrasound because it doesn't have radiation. In recent years, we have used MRI because we want to avoid CT scan as much as possible. But if but especially young children, those children who cannot tell us that they have pain, how many days, where is the pain. So they're usually very young. And those are the children that you don't want to radiate them because of the risk of cancer later on. So I think you're correct. Like, you know, in terms of the one who are very young, we have to be much more careful because they are not going to be able to offer us a whole lot of clues in terms of what is causing their discomfort, abdominal pain.
Okay, thank you for your time, Dr. Thomas Wee. Thank you for your informative and understandable lecture. We hope next time we will invite you and sharing your knowledge again in this faculty. I return the session to MC.
Thank you, Mr. Thomas Hui, for the great, informative, and insightful presentation and discussion, and Mr. Terang Meliala as our moderator. Excellencies, ladies and gentlemen, we have finished the plenary lecture. Thank for all the speakers. Those are very useful and insightful information. Honorable participants, now we come to our third symposium. Symposium session from Professor Endang Sutriswati Rahayu, Professor Badriul Hegar, and Mr. Leo Simanjuntak, will be led by our moderator, Mrs. Runggu Retno Napitupulu. Mrs. Runggu Retno, time and place are yours.
Thank you. Thank you, Dr. Christine, as Master Ceremony. Good morning, ladies and gentlemen. May I have still your attention? Welcome to this symposium session. I would like to welcome you all to this presentation. In this occasion, we would like to have a presentation about the role of probiotics. Before the presentation begins, allow me to introduce the presenter. The first presenter is Professor Dr. Insinyur Endang Sutriswati Rahayu MS. Professor Dr. Insinyur Endang Sutriswati is lecturer at Department of Food and Agricultural Product Technology, Faculty of Agricultural Technology, Universitas Gadjah Mada, Yogyakarta, Indonesia, since 1980. Her major field is food microbiology. Her research works and publications are mainly related to lactic acid bacteria, probiotics, gut microbiota, and food safety. She belongs to several professional associations, such as of Indonesian Society of Microbiology, as Indonesian Society for Lactic Acid Bacteria and Gut Microbiota as a chairman, Asian Federation of Society for Lactic Bacteria as a chairman since 2017 to 2021, and member of International Commission on Food Microbiology, ICFM. Currently, she is coordinator of University Center of Excellence for Research and Application on Integrated Probiotics Industry at Center for Food and Nutrition Studies, Universitas Gadjah Mada. Without further ado, I would like to welcome the presenter to deliver the presentation. Professor Dr. Insinyur Endang Sutriswati Rahayu MS. The floor is yours.
Thank you, Bu Moderator, for introducing me. Good morning, everybody. First of all, I would like to thanks to the organizer who already invite me to talk about probiotic, particularly for Dr. Leo. Thank you. Hope in the future we can make a collaboration, particularly related with probiotic. My slide first. Here is my CV. Yeah. Title that given to me, it's a probiotic, role of probiotics in infectious disease. I hope I could, can I use this one? Oh, this one not related. Can you put this one into your computer so that I can operate myself? Yeah, I would like to talk about introduction, criteria for probiotic, normobiosis and dysbiosis, probiotic mechanisms in prevention, infectious disease, and probiotic indigenous lactobacillus, result of a long study at the Universitas Gadjah Mada, and then conclusion. Okay, next slide, please. Next slide. Yes. Okay. Now about the definition of probiotic. Probiotic is defined as a microorganism that when administered in adequate amount confer health benefit of the host. And then this definition, it's come from FAO WHO 2002, and then renewed by the International Scientific Association for Probiotic and Prebiotic. Probiotic must define contents, appropriate viable count at the end of shelf life, and suitable evidence for health benefit. And further stated that all probiotic must be safe for intended use. So, the criteria used for probiotic: accurate taxonomy identification. So we can understand now, like lactobacillus, the new generites, lactobacilli, lactobacillus, yeah, so that's for probiotic, the current taxonomy must be used. And then safe, non-pathogenic or generally recognized as safe, ability to colonize the host, adherence to intestinal epithelial cell, and produce antimicrobial component against pathogen. This is our topic today. And the other criteria: inability to exchange materials, particularly antibiotic resistant genes, and have potential benefit. Yeah? This potential benefit to the host should be proven by clinical trial phase 2. Next slide. Yeah, okay. Actually, there are several characteristics of probiotic in food. Yeah? Not only physiological characteristic, but also functionality, yeah? Health benefit to human characteristic, including technological characteristic, considering when this probiotic will be industrialized. Yeah? So the characteristic is not only antimicrobial profile and also ability to colonize in the gut and also adherency here that support for for the treatment of infectious disease, but there are several characteristics for the screening. Like here, for example, anti-cholesterol, we would like to do a research on that, reduction of cholesterol, anti-mutagenic, anti-carcinogenic, and anti-allergy, and so on. This can be proven by clinical trials. And then we can see here, for today's, against infectious disease, the mechanism action of probiotic, there are at least 4: competitive exclusion of pathogenic bacteria, production of antimicrobial substance, increased adhesion to intestinal mucosa, and improvement of epithelial barrier, and also stimulation of the immune system. Here is the mechanism. Next slide, please. Here is a depict some photo. Photo when the probiotic bacillus, lactobacillus here attach the intestinal cell. And while in the right photo here, at the beginning, Escherichia coli attach the epithelial cell. We can see here. However, after the addition of probiotic, Bifidobacterium adolescentis here, this probiotic is producing adesin. We can see here clear. There is no attachment of Escherichia coli. So it means here that the probiotic can produce substance that inhibit the growth of Escherichia coli. Okay, next slide. Here what we call it the balance of intestinal biota. When our condition it's healthy, we can see here the symbiotic microbiota increase the number, overgrowth, compared to the pathogenic. When the good bacteria dominant in our intestine, there are several beneficial effects to the host. However, when the pathogenic bacteria increase the number, there is a problem occur. We call it here, it's a gut dysbiosis. So, balanced gut microbiota will support the health, particularly gut health, and also including body health. Okay, next slide. There is a mechanisms between healthy molecular microbial community, healthy gut microbiota community. Then here when the intestine in the dysbiosis condition, we can see here pathogenic cannot attack because a lot of good bacteria here. However, when there is no protection, and also including the use of antibiotic here, pathogenic bacteria can attack our intestine, here in Salmonella, Shigella, Clostridium difficile, including toxin producer, when they are overgrowth, translocation occurs, infection also occurs. This is the mechanism when the pathogenic bacteria attacks our intestine. Okay, next slide. Similar to this, the mechanism is similar, written by other author, similar here. This one when the healthy condition, and then when the dysbiosis occur, some pathogenic bacteria can enter to our blood and then cause the several diseases. Okay, next slide, please. I have several publications related with gut microbiota, with respondent of obesity and also type 2 diabetes. Our publication prove that dysbiosis occur in the respondent having diabetic and also obesity. And also dysbiosis also occur in malnutrition children in Yogyakarta, and also undernourished children. We have studied comparison between healthy children at Yogyakarta and also undernutrition children from Lombok. We have a conclusion that actually in the malnutrition children, dysbiosis also occur. When dysbiosis occurs, we can, we can say that infection may be also, because no protection in the intestine, so infection easily occur. So, actually, now dysbiosis not only related with our intestine, but also what can affect also the brain and also liver and also lungs here. So we call it gut microbiota brain axis and gut microbiota liver axis and gut microbiota lung axis. So during dysbiosis, the question is, can probiotics restore the balance of gut microbiota and maintain health of intestine? So the question. So many diseases now correlate with dysbiosis, and then how about the role of probiotic? And today our topic is a probiotic related with infectious disease. That's the main purpose of probiotic is to make the healthiness of our intestine. Okay, next slide. Yeah, this one probiotic mechanisms. There are at least 3 mechanisms. The first, protective function, particularly against pathogen. And what's here? Yeah, the protective function, it's through colonization of probiotic. Yeah. As I mentioned in the criteria, that probiotic must alive in the intestine, yeah, colonize in the gut. Yeah, that's the main criteria for probiotic. So, and then when the probiotic colonize the gut, compete for the nutrient with pathogen and competition for the adhesion site, secretion of antimicrobial substance by probiotic, yeah, and then also probiotic can lowering pH and stimulate epithelial mucin production and enhance intestinal barrier function. Okay, this is the main mechanism of probiotic in the treatment of infectious disease. The other mechanism is immune function, immune system function, and also metabolites function. Next slide, please. Okay, actually, World Gastroenterology Organization already published, yeah, guideline for the use of probiotic and prebiotic. Again, in the guideline here mentioned that the health benefit probiotic are strain dependent. Yes, strain dependent with the effective dose about 10 to the power of 8 to the 10 to the power of 11. The health benefit of each probiotic from experiment must be well documented and cannot be generalized to other strain. Yeah. So if we, in the publication, that one strain used for reduction of weight, of course, the other strain cannot also be used for the reduction of weight unless, yeah, clinical trial proven. Yeah. So in here we can see several strain. Yeah. Top is Lactobacillus casei cirrhota. Yeah. Probiotic in the market at first. Yeah. This is not commercialization, but this is the fact. Cirrhota, it's a strain probiotic, the first in the world. Yeah, until now, after 100 years, Cirrhota still exists. Yeah. Cirrhota in the market used as a starter for the production of Yakult. Yeah. So this the first probiotic strain in the world and already 100 years. Okay. Next slide, please. Yeah. So, according to WHO, yeah, probiotic can be used to treat several diseases, but our topics now it's related with pathogen, including, yeah, antibiotic associated diarrhea. Next slide. Yeah, here is strong mean number 1, yeah, strong mild evidence of several probiotic strain in treatment of adult diarrhea, antibiotic associated diarrhea, and prevention of Clostridium difficile associated diarrhea. So, yeah, in the review by WHO, yeah, there are actually several. This is clear, yeah, clear the strain number.
Sorry,
Okay.
Prof,
Next
the
slide.
time is 2 minutes again.
How
Minute
many
more?
minutes?
Yes, 2 minutes.
2 minutes, okay. Next slide, please. Yeah, this one for Helicobacter pylori eradication. Next slide, please. Yeah, next slide. Next slide. Yeah, this is the slide actually complete. If you want to have this slide, so you can copy from the organizer. Next slide, please. Yeah, this one probiotic produced by our center. Yeah, we have done long research on probiotic, and now our candidate is Lactobacillus plantarum subspecies plantarum dat13. Yeah, the current taxonomy name is Lactobacillus plantarum. Yeah, this evidence already proven, and you can visit to our website. Next slide, please. Yeah, including several clinical trials. Yeah, we have done clinical trial for malnutrition children, diabetic respondent, and also obesity. And the last I would like to mention about our probiotic used for OTG patient, COVID-19. Next slide, please. Yeah, this one I brought a brochure, so maybe you can have, yeah, in the tables. Okay, next slide, please. Yeah, probiotic in COVID-19. Next slide. Yes, we have done this experiment during October to November 22. Next slide, please. Yeah, with the 3 sites of study. Next slide. Yeah, from Buleleng, Bali, Sleman, and Bantul. Total about more than 200 respondent pasien OTG COVID-19. Next slide. Next slide. Yeah, this very important result. Yeah, we can see here we check the fecal quality using a Bristol scale between 1 to 7. One, the green color here, 1 and 2 considering constipation, and then blue considering normal, and red color considering diarrhea. We can see here that diarrhea, yeah, occurs more number compared to the treatment patient. Yeah, the left one is placebo, and the right one is treatment. So we can see here actually, yeah, probiotic really can reduce the diarrheal cases in patient OTG COVID-19. Yeah, this is our surprise result at the time. Yeah, okay. The last slide. So we can conclude that probiotic play important role against the infectious pathogens via their effect on the epithelium, production of antimicrobial compound, and competitive exclusion. Administration of probiotic supplement may reduce the risk of infectious disease and the use of antibiotic. Yeah. Hence, contributing the reduction or delay of the development of multi-resistant bacteria. Indigenous probiotic Lactobacillus plantarum dat13, a bacteriocin producer proven to reduce diarrheal cases, has the potential to be used in the prevention and treatment of infectious disease. Okay, thank you very much for your attention.
Thank you, Prof. Endang, for the insightful presentation. Many things want to share with Professor Endang, but we don't have time. The second presenter is Profesor Dr. Badriul Hagar, Spesialis Anak Konsultan PhD. Professor Hagar has been a staff member in the Pediatric Gastrohepatology Division Department of Child Health, University of Indonesia from 1995 until present. He got his PhD in Free University of Brussels, Belgium in 2011 and professor in pediatrics from University of Indonesia in 2017. Since 2017, he has been appointed as Director of Indonesian Medical Education and Research Institute, or IMERI. Currently, he is participating in several professional societies. He also became editor in Indonesian Journal of Gastroenterology, Hepatology, and Digestive Endoscopy and Pediatrica Indonesiana. He received several awards for his contribution in research and organization development. He has more than 130 of international and national scientific publications. Now, we please Prof. Hagar to present the presentation. Time is yours, Prof.
May I ask, there's my slides already there, clear? Is the
Yes.
moderator?
Already clear, Prof.
I cannot hear you clear. Okay, thank you very much, everyone. First of all, I would like to thanks for the committee and also for the media moderator for the introduction. And also apologize because I could not attend together with all the participants in Medan. So I would like to start my presentation with the title of the implementation of probiotic in children in daily practice. If you are talking regarding knowledge about the microbiota, so we know that the impact of the composition of gut microbiota on health is increasing and promising. But by having this data, we also know that the microbiota composition disorder us as the cause of the disease and not as the results. We also have the data from the data resulting right now that the microbiota composition changes in every situation and it makes difficulty for us in making conclusion for the result data. Talking about the probiotic, as already mentioned the definition by the previous speaker, there are some clinical evidence with the good multiple randomized trial and also meta-analysis in treatment of acute diarrhea and also in prevention of antibiotic-associated diarrhea. But for the other condition, they're still limited or a single randomized trial. Through years, so they are also increasing data with the good multiple randomized trial, also meta-analysis in the treatment of colic and also in recognizing enterocolitis. But the other conditions still in limited and single randomized trials. So if we are supplement probiotics, so I hope they will be act as the protective function against the pathogenic bacteria with separate pathway and also increasing the development of the immune system and also act the digestive and metabolic function. For example, how the fermentation on the non-digestive carbohydrate. This is one of the example how the probiotic ferment the non-carbohydrate digestive. For example, the human milk oligosaccharide. They produce the short chain fatty acid and they make the decreasing of the pH lumen and also the increasing of the production of the mucin. And together with the antimalarial factor, they improve the intestinal barrier function and they act to prevent the adherence, standard location of the bacteria across the epithelial wall, and also the activation, the balancing the immune system to suppress the inflammation and as well the thickening, the tightening of the junction. This is the data. I want to see the slide of how the probiotic efficacy of the probiotic and the treatment of acute diarrhea. There are several data by the meta-analysis. The including study used the probiotic bacteria in the various from bifido and also lactobacillus, but that we can see the reduction of the duration of diarrhea regarding about 70 hours until 13th hour in this kind of a study. There also another study from the meta-analysis of the Cochrane data regarding 23 studies in the criteria. They show that probiotic reduce the risk of diarrhea at the 3 days and the mean duration of diarrhea by 13 hours. There's also some studies show the similar data regarding dose dependent. Also, they reduce diarrhea by 13 hours, and also the important early use probiotic to have the greater benefit in acute diarrhea. This study I want to show the same as endpoint, but they use the multi-strain of probiotic. But they also show the same data. They're reducing the duration by 1 day regarding 24 hours by having probiotic or not. And also they influence the consistency of the stool, and also they decreasing the additional medication that's always given to the baby who have the diarrhea problem. There's another data I want to show that with the different strain of the probiotic, they show there's no effect on rotavirus, but they ameliorates the outcome of the non-rotavirus diarrhea in children in Bangladesh. They just want to show the final data by the having of the study. Of course, there are also some study with the negative result, even with the same strain of the probiotic. We can see there's the sum of the strains of probiotic, the different result with the even there in on point of the duration of the stool, duration of the diarrhea, following the stool, duration of the number of the stool, and also duration of hospital days. Even there is quite strong data on probiotic on to treat in the diarrhea children, but there are still not really strict recommendation on that. For example, this of Eskan and Nazga still just mentioned a very general one. They said a probiotic may be an effective adjunct to the management of the acute diarrhea. They don't mention a very strict recommendation on that. Okay, there's also study want to see how the effect of probiotic to prevent the acute diarrhea. Of course, they put in the milk product supplementation because they want to see the long-term effect. We can see from this data that bifidobacteria are particularly attractive as a probiotic agent because they constitute as the predominant colony flora in breastfed infant gut. Okay, there's another study. There's another to show with the under condition. You can see this several study want to see how probiotic to prevent the antibiotic-associated diarrhea of some children. We can see that the reduction of the incident is appear to be 70% regarding 45 and 48 antiseptic. But I think what good data to see how the efficacy of probiotic to prevent antibiotic-associated children, both by bifido and also lactobacillus. Okay, this data also want to show us how this analysis want to show that some several study with the several strain of probiotic give the impact of the prevention of antibiotic associated in children. However, there's also one concrete study want to show us they still show that there's not insufficient evidence to bring all the data to be recommended because most of them still the single trial what they are analyzing on this Cochrane data. There's another study want to see another condition. They want to see how the effect of probiotic for prevention of the enterocolitis in preterm infant. From this analysis, we can see several data give us the data how they can prevent necrotic enterocolitis in preterm infant. This data also want to show us how the sequence analysis by having 300 premature infant, they show that the prophylactic use of probiotic protect the statistically significant reduction in neck rates in high-risk infant in NICU. And also they show that the surgical neck and death from neck was reduced from 8% to 2%. And also there are no different effect reaction compared to the placebo one. This data also want to show us how the effect of the bifidobacteria as a probiotic with supplementation at the very long-term infant, how they can prevent the neck in the neck of this study. There's a statistical review. They can see the several of bifidobacteria strain have the impact of this kind of prevention. There's another study want to see how with the other condition. One of the most conditions that has been studied with the very several data as well, very interesting to know, is constipation. You can see there are some data in functional constipation in children. I want to show some several data. First data show us that there's the impact by having probiotic in functional constipation to increase the frequency of the bowel movement at 4 weeks. But there's no difference in stool consistency. But the other study in here, they show that there's significant benefit effect for the symptom because of the decreasing of the gas content because of the dysbiosis of the gut by in children who have suffered from constipation functional. But we have seen another data. You can see that the first data show us how the Bifidobacterium breve give a positive impact in consistency, in continentia, and also in abdominal pain. However, this who work in this study is still not confident to bring it to the recommendation. They say that there's still more data to confirm these results. We can see for the other study, we can see that there's no significant difference between the regular treatment of constipation or with the additional with the probiotic in improvement after 1 month or in the general of clinical remission. So we can see there's still the better data to be can be recommended. For another study, there's another study with other conditions. We can see there's study on infantile colic. There's a systematic review from 10 papers. They can say what the conclusion of this research say that there's specific strength of probiotic that extraordinary efficacy for the treatment infantile colic because their role in anti-inflammatory effect of the microbiota and also because the gut microbial hemostasis. So we can see that from this study review, they can say that the probiotic are effective for treating infantile colic because the efficacy to their anti-inflammatory effect. However, the complicated base of infantile colic, the limitation in the treatment levels, they still lack of the data to bring it for the strong recommendation. But they show that specific strength of probiotic may be introduced as a new therapeutic for the colic infantile. This is also another data from the Konferensi data want to say, based on the theoretical point of view, we know that there's an anti-inflammatory gene of the effect of the microbiota, and also they can improving the gut function motility, and also the exertion of the reduction of the visceral pain. However, by the final results of the analysis, they show that their daily carrying time seem to reduce in specific infant and also in specific strain of probiotic compared to placebo. But they're not confident to bring it to the strong recommendation, but they still put as the consider in certain conditions. They also mentioned that there are no clear evidence as to preventing infantile colic condition. I just want to show to study, the first study in the left want to show there's significant difference between microbiota and probiotic with the placebo one. But the other study want to show with this what the equal data, there's no difference at all because there are also 66% respond by placebo to give the more decreasing the symptom of the infantile colic patient. I just want to show you all there's still the battle in data, so we have to be careful as doctor to bring it to our patients. Another condition is irritable bowel syndrome. Is one of our gut gastrointestinal functional. There is a data that significantly different in one group placebo, in the other with the supplemented by the probiotic. So there's a significant difference in abdominal pain resolution and also improving abdominal of the frequency. So we can see from the data that in children with IBS, Bifidobacteria maybe is associated with the improvement of abdominal pain and also in the quality of life of the children. But however, I want to show another data in irritable bowel syndrome. The first data show us there is no evidence, in supplemented this in the management of children with recurrent abdominal pain. But the second data was show us there is efficacy of the IBS. Even the magnitude of the benefit are uncertain in this study. And the third study want to show us.
Sorry, Prof. The time is 2 minutes more.
Even the respondent is very long, and there are no significant difference. I think this is the last condition. I just want to show two data. The first data want to show us there is a significant difference in the remission, also in the ransom. But the other want to show us there is insufficient data to make the conclusion to bring it to the chronic disease. I just want to show of the conflicting data of probiotic infected. Because the data we are doing in the infant and young children, so safety is very important one, yeah, for us as a doctor to have this data. And because there's many data, they show us good data on probiotic. However, there's still also prescribing probiotic with the not strong enough data based on this condition. I think we have to be careful because we are doing in children also in infants. There's some study want to show how safety report by this study by this product. So I think it's a responsibility of the industry how they make sure the product there's no bacteremia, there's no toxic inflammatory effect, also there's no transfer of resistant antibiotic. I think it's my slide to show us the conclusion. First, this probiotic has been shown to be moderately effective in acute diarrhea and also preventing acute diarrhea. And there's also some evidence that probiotic can prevent, not very front, but I think there's more study to be needed. There are also the result of probiotic in treat of infantile colic. However, the encouraging still require further confirmation. And the last one is probiotic has not been proven to be beneficial in treating children with chronic disease. Thank you very much for the attention. Terima kasih.
Thank you, Prof. Hagar, for the interesting presentation. Next, we want to hear the presentation from Dr. Leo Simanjuntak, SPOG, Specialist of Gynecology. I want to read the curriculum vitae. Dr. Leo Simanjuntak has been a Dean Faculty of Medicine Universitas HKBP Nommensen since 2020 until present. He got his obstetrician and gynecologist from Faculty of Medicine Universitas Sumatera Utara, then the doctoral from Faculty of Medicine Universitas Sumatera Utara. Now, areas of interest of his research are preeclampsia, probiotics, immunoendocrinology, vaginitis, and infertility. Now, the time is yours, Dr. Leo Simanjuntak.
Thank you very much, Dr. Runggu. Good morning, everyone. Good morning, Prof. Endang. Thank you very much for coming to Medan. Allow me to present my paper in English, but like to explain it in campur-campur, yeah. Some in the English and some in Bahasa. Right, Dr. Surjit? Okay, thank you. Okay, next slide, please. Yes. Now I'm talking about the, after the Prof. Endang talking about probiotic in infectious disease, Prof. Hagar, probiotic in the children, and now what about the probiotic in the obstetrics and gynecology? As you can see here, some said that probiotic also has a beneficial effect in preeclampsia, but it is still under investigation. And in gestational diabetes also. And now we are talking about the vaginitis. Next slide, please. Yeah. There are three types of common vaginitis. The first one is bacterial vaginosis. This is the most important one because 40 to 45% of symptomatic leukorrhea is bacterial vaginosis. Means if you are now having a symptomatic leukorrhea or keputihan, it means 40 to 45% maybe you are having bacterial vaginosis. Slide, please. Yeah, this is the study about the prevalence. Yeah, here we are in Medan. We found 40.7%. Dr. Surjit, this study we conducted in Universitas HKBP Nommensen, yeah, the staining and microscopic examination also in our research laboratory in third level over there. Slide, please. Well, what is BV? BV actually is not a true infection. The organism does not come from outside, but the organism already inside the vagina is a normal flora, but you can see here dramatic changes from the predominance of lactic acid bacteria to anaerobic bacteria. So it is not a true infection. It is only the changes of the normal flora inside vagina. Slide, please. Thousand-fold increase in anaerobic microorganism and 100-fold increase in Gardnerella vaginalis. Slide. And this is another study, the prevalence of BV. Here we are in Medan found 44% the BV in symptomatic leukorrhea. Slide. Yeah. Why BV is important? Because during pregnancy, the BV associated with some complication, miscarriage, keguguran, abortus, preterm labor, and so on. Slide. What is the risk factor? The study showed the main risk factor of BV is vaginal dosing. So, you have to take a great care when you are using vaginal dosing. This is the main risk factor of BV. Slide. Yeah, this is the study about the vaginal dosing conducted by Brodmann et al. Slide. And in summary, they said that vaginal dosing may confer increased risk for disruption of vaginal flora. So, if you are now using vaginal dosing, you have to take care for using that because the vaginal dosing will disrupt your normal vaginal flora. Slide. Now, probiotic and bacterial vaginosis. Slide. Yeah, Prof. Endang has told about this probiotic. Slide. Yeah, why probiotic need for BV? Why? Because there is a resistance. We found the resistance for standard treatment of BV and recurrent infection, and also the side effect of antimicrobial such as nausea, vomiting, and so on. Slide. Yeah, we can see here the current treatment, standard treatment, show the recurrence rate up to 80%. Up to 80% the recurrence rate after the standard treatment. Slide. How probiotic work? Prof. Endang also already talked about this. Slide, please. This is a study conducted by Anukan. Anukan said that intervention group using probiotic and placebo group without probiotic. Slide. And the probiotic group, the cure rate 88%, and in placebo group, the cure rate 40% and significantly different. Slide, please. Another study by Parent. So this is a probiotic plus estriol compared to placebo plus estriol. The cure rate is 87.5%. It means that probiotic is superior to standard therapy. Slide. And the recurrence rate. This is the study conducted by Cohen, 2020. The probiotic group, of course, there is a recurrence after 12 weeks, but only 30% compared to placebo group without probiotic, the recurrence rate higher, 45%. Slide. But this is a little bit pessimistic conclusion from the Cochrane library said that the probiotic appears promising. So this is a little bit pessimistic conclusion, I think. Yeah, but other studies show the superiority of the probiotic compared to standard therapy. Slide, please. And this is the study for the non-pregnant women. Slide. Yeah, there are 3 groups here. The group 1, antibiotic plus probiotic. You can see here the antibiotic plus probiotic superior to antibiotic alone. And this one, probiotic compared to antibiotic. The probiotic, you can see that the antibiotic is superior to probiotic alone, but the third group, probiotic compared to placebo, no therapy, the probiotic is superior compared to placebo. We can see the study that it means that probiotic alone is very, very superior compared to placebo. Slide. Slide. Another study, I think it is conducted in Malang also, review 16 RCTs. Slide. Yeah. Here we can see that the odds ratio of probiotic is 3.3 compared to placebo. Slide. And the conclusion of the study, the cure rate of probiotic group are significantly higher. The second one, the recurrence rate significantly lower. And the third one, the adverse effect not different. The adverse effect or complication by the probiotic not different in both groups. Slide. Probiotic in pregnancy. Slide. Yeah. Also, they show the cure rate superior after using the lactobacillus, 88% compared to no lactobacillus. Slide. Yeah. Another study, the perinatal. What about the perinatal outcome? Perinatal outcome. Slide, please. Yeah. The probiotic using during pregnancy does not have any positive or negative impact on birth weight, length of gestation, and cesarean section. Slide, please. What about probiotic in gestational diabetes mellitus? Slide. It showed that the probiotic reduce the risk of newborn hyperbilirubinemia, improve glycemic control, and improve blood level lipid profile, and improve the inflammation and oxidative stress after using the probiotic in gestational diabetes. Slide. Yeah, what about the urinary tract infection? Also, the probiotic seems to reduce the recurrence rate from 6 to 1.6 per year. Significantly different. Slide, please. Yeah, slide, please. just the same, I think, yeah. But the study from Cochrane show the using of probiotic during pregnancy, we have, to pay attention because this data show that there is a increasing of the hypertension. Hypertension, this is the placebo only 35 per 100,000, 35 per 1,000 patient, but in probiotic increased to 65 per 1,000. So this is a high certainty of the evidence. It means in case of incidence of preeclampsia, they said that probiotic probably have a harmful effect for hypertension during pregnancy. Slide, please. Slide, please. Yeah, slide, please. But other studies show by Brandsetter that the probiotic lower the risk of preeclampsia. So it means one study say increase the risk, but another study say lower the risk. So what does it mean? We need more study with more participants to make a good conclusion about the probiotic in preeclampsia. Slide, please. Slide, please. Yeah, it's okay. The recurrence, yes, I just said before, 30% recurrence with probiotic, 40% in placebo group. Slide, please. This is the take-home messages. BV remained a serious problem for reproductive age women, in particular during pregnancy. Probiotic alone might have a therapeutic effect on BV compared to placebo. Probiotic increased efficacy of antibiotic for treatment of BV. Slide. Slide, please. Probiotic lower the recurrence rate of BV significantly, but Cochrane remind us that probiotic may have a negative effect because probiotic increase the risk of preeclampsia during pregnancy. Slide, please. Thank you very much.
Thank you, Dr. Leo, for the interesting presentation. Now we will come to the question and answer session. But before that, I want to permission to make a discussion in, like Dr. Leo said, campur-campur. Ini adalah topik yang sangat menarik, yang sayang kalau khususnya para sejawat dan teman-teman tidak ikut terlibat hanya karena mungkin not have a good English. Jadi kita bisa campur-campur, silahkan siapa yang mau bertanya dalam bahasa Inggris, siapa yang mau bertanya dalam bahasa Indonesia silahkan kepada para sejawat dan kepada para mahasiswa kami sekalian. Now we invite Prof. Endang and Dr. Leo to join us. Anyone have the question? Ada yang mau bertanya? Silakan. Oh ya, baik. Silakan. Sebelumnya dipersilakan untuk berdiri, kemudian tolong sebutkan nama untuk memudahkan para presenter kita menjawabnya. Terima kasih.
Selamat siang, dokter dan profesor semuanya. Perkenalkan, saya Juela, mahasiswa Fakultas Kedokteran HKBP Nommensen. Izin bertanya dengan menggunakan bahasa Indonesia. Pertanyaan saya ditujukan pada Prof. Endang. Izin bertanya, Prof, saya ingin mengetahui korelasi antara probiotik ini dengan infeksi Helicobacter pylori. Mohon jawabannya, Prof.
Iya, tadi yang saya jelaskan itu berdasarkan review yang dilakukan oleh World Gastroenterology. Ya, jadi memang untuk Helicobacter pylori ini sebentar saya harus membuka slide-nya. Mungkin evidence-nya masih ini ya tidak terlalu kuat ya. Namun bisa digunakan untuk mengatasi terjadinya ini kasus berulang begitu ya. Saya harus melihat ini.
Boleh tolong kepada tim multimedia ditampilkan lagi presentasi Prof. Endang.
Sebentar, ini baru saja atau pertanyaan yang lain.
Oh, boleh, silakan sambil Prof mempersiapkan jawaban. Silakan kepada yang lain untuk bertanya. Maybe the other audience. Any question? Oh, dari Zoom. Dari Zoom nggak nampak di sini. Boleh bantu mungkin Dr. Janri? We cannot see the question in this Zoom. Can we help? Yeah. Okay. Please, Dr. Amran. From the Zoom or your own question?
Questions.
Please. Please, Dr. Amran. Bentar, boleh Prof. Amran? Okay. This is a question for Prof. Hegar. To Prof. Hegar, my question is, should probiotic administration is a recommendation since for non-breastfeed baby to promote a healthier gut? And to Prof. Endang, my question, Prof. Hegar first. Sorry, Prof, we can't hear your voice. Maybe tim multimedia can help?
Can I answer the question?
Yes. Yes. Please, Prof.
Thank you very much. I will try to answer the question. In Indonesia, I think, yeah? In English?
Indonesia, Prof.
Okay. I think there are some risk factor of the baby when they deliver. First, for the mode of delivery, sexual or vaginal. We know that there is the distribution of the gut microbiome composition by the delivery of the sexual secara. The second one, feeding, and the third one, there's hospitalized individual ward or not, and also the environment. For example, this kind of baby, they delivers, but they by sexual etc. as for example, but they still can have the breast milk. There is no worry because in the breast milk there's probiotic. There's also as well the prebiotic. But if the delivery sexual cesarean and the mother could not give exclusively breastfeeding to the infant, maybe there we can think the possibility to manage the gut microbiota composition in the gut of the infant by supplement with kind of microbiota, because there are two risks as that having of this kind of infants. Gitu kali Bu, thank you very much.
I hope that's clear. This is another question for Prof. Endang. Should antibiotic and probiotic administered at the same time in infection cases?
Yeah, some antibiotic also killed, by some probiotic was also killed by antibiotic. So it's better not use together. Usually, advice, use antibiotic first, because antibiotic also can produce, can make dysbiosis in our intestine. And then after sometimes followed by the consumption of probiotic. So that's my answer. Yeah.
Okay,
So
thank you,
don't
Prof.
use together, but
Okay.
if of course we can use together, but the effectiveness of a probiotic living in our intestine, it's maybe still low. Yeah, because particularly the antibiotic could kill the probiotic. So use after the treatment of antibiotic finished.
Prefer not use in the same time.
Yeah.
Okay, maybe?
Yeah.
Okay.
I already reached the summary by the WHO. Yeah. Oh, ya, nggak apa-apa. Ini juga bahasa Inggris di sini. Jadi untuk Helicobacter, ya, jadi probiotik usually use as a co-adjuvant therapy, terapi tambahan untuk pasien yang disebabkan oleh Helicobacter pylori. Probiotik tidak digunakan untuk mengatasi Helicobacter pylori, tetapi digunakan sebagai tambahan. Itu pun kalau dilihat buktinya memang ada beberapa strain yang positif, ya. Saccharomyces boulardii itu bisa reduction in therapy related side effect. Jadi probiotik targetnya adalah pada side effect yang side effect akibat infeksi Helicobacter pylori. Jadi kalau dari review itu probiotik bukan digunakan untuk mengatasi Helicobacter pylori, tetapi sebagai istilahnya co-adjuvant aja.
Thank you, Prof. Bagaimana, sudah bisa terjawab? Semoga sudah, ya, sepertinya sudah cukup jelas. Baik, now it's your turn, Dr. Amran.
Ya, terima kasih Prof. Endang, saya Amran. Sejauh ini Prof, yang ingin saya tanyakan, untuk penggunaan probiotik, apakah dia berguna di bidang THT, khususnya di bidang subspesialis saya, rinologi, yang saya nangani sinusitis baik akut maupun kronis, apakah itu sudah ada kemanfaatannya, Prof? Itu pertanyaan saya.
Itu menyinggung saya juga, ya, Dok, ya. Hidung saya karena kurang mancung jadi lemah. Ya, jadi selama ini memang penggunaan probiotik banyak dikaitkan dengan beberapa kasus, ya. Seperti, ya, ini kasus yang saya alami, ya, karena adanya
deviasi.
Ini, ya, enggak tahu ini saya karena enggak mau operasi itu kan, terus kemudian menjadi mudah terinfeksi. Nah, di sini peran probiotik itu adalah untuk menjaga kesehatan usus, dan ternyata usus yang sehat itu juga menstimulasi sistem imun yang kuat. Jadi seperti itu, tidak direct, tetapi indirect. Kesehatan usus, ini yang selalu saya promosikan ya. Kesehatan usus itu menyebar ke kesehatan seluruh tubuh. Karena ternyata saya peneliti gut microbiota sehingga banyak data terkait dengan dysbiosis yang ada di usus kita itu. Nah memang kalau kita rutin dengan konsumsi probiotik ataupun makanan sehat ya yang juga menstimulasi kesehatan usus, itu ternyata sistem imun kita juga baik dan semoga juga mengarah ke seluruh tubuh termasuk hidung. Begitu. Jadi kaitannya tidak direct tetapi indirect melalui sistem imun tubuh. Ya.
Terima kasih Prof. Endang.
Masih ada waktu?
Silakan.
Terima kasih Dr. Retno Runggun, saya Dr. Ita. Ini saya berbagi pengalaman saja ya. Dan bukan apa-apa, kemarin saya lihat berantri mengambil Yakult di belakang sana. Tapi kalau saat ini nanti saya 1 ember Yakultnya ya. Bukan apa-apa, karena Yakult ini juga kan suatu probiotik ya Prof. Endang ya. Ini pengalaman pribadi, ketika pandemi COVID-19 kemarin, saya paling rajin mengkonsumsinya. Salah satunya probiotik tersebut. Jadi ya syukur alhamdulillah saya tidak kena COVID-19 sampai saat ini. Jadi saya kira probiotik ini udah perlu dibagikan kepada kami-kami ini. Terima kasih.
Nanti dibagi.
Baik, mungkin ini pertanyaan untuk, ada lagi pertanyaan? Ya, oke baik. Silakan Pak mahasiswa dulu ya Prof. Dr. Sujit mahasiswa dulu ya.
Oh ya, please.
Bagi semangat ini mahasiswa bertanya.
Semangat ya, kasih kesempatan kepada
karena udah dibagi itu
mahasiswa
juga.
dulu ya, silakan.
Ya karena udah dibagi juga dokter kan kita.
Ya, nggak apa-apa, mahasiswa dulu.
Baik, terima kasih atas waktunya. Pertama-tama nama saya Dea Adriana Meliani, saya mahasiswa dari Stambuk 2021. Saya ingin memberikan pertanyaan pada Dr. Leo. Pertanyaan saya itu, jika pasien dalam kasus preeklamsia ini, apakah tindakan yang dapat dilakukan jika pasien tersebut menunjukkan tanda-tanda eklamsia? Jika harus dilakukan persalinan, apa rekomendasi persalinan tersebut? Jika melakukan persalinan SC, apakah seksio dapat memperburuk pasien dikarenakan ada obat anestesi tersebut? Terima kasih dokter.
Baik, silakan.
Ya, jadi terima kasih apa tadi Ananda ya, Ananda. Ya.
Dia
Ya,
ya.
memang ini topik kuliah ini nanti. Kebetulan pakarnya dari sini nih, Prof. Sarma ini. Jadi nanti kalau masalah preeklamsi, eklamsi itu nanti di ruang kuliah lebih dalam lagi. Tapi yang saat ini kita diskusikan itu adalah masalah probiotik dalam kehamilan tadi. Kalau ada ibu hamil diberikan probiotik, hati-hati. Tadi itu apanya? Hati-hati bisa menyebabkan kenaikan tekanan darah sebenarnya. Sebagian dibandingkan dengan yang tidak dapat probiotik. Jadi di situ ininya. Di situ concernnya. Jadi hati-hati di situ. Jadi nanti kalau masalah penanganan preeklamsi itu dalam bangku kuliah nanti kita perjelas. Ya, saya kira gitu, Dr. Runggu.
Baik,
Ya,
terima kasih. Ya, nanti diperjelas waktu di kuliah ya. Baik, Dr. Sujit, berhubung waktunya habis, maksudnya silakan singkat saja singkat.
Yes, singkat aja ya.
Ya.
Prof. Endang, tadi saya agak ngantuk-ngantuk, tapi setelah konsumsi Vipilak ya, ini ada mumpung. Rasanya energi saya bertambah, semangat gitu. Direct evidence ya, ini bukan promosi, bukan. Medan Jogja. Yeah, it's very interesting. Yeah, we have a lot of studies especially Prof. Endang, in India also, people are very fond of eating probiotics because milk is available and they make yogurt, you know. And even during the pandemic, COVID pandemic, so there are some studies in India also. It said that maybe most of the patients, they had very high protection from COVID-19. Yeah, so I really appreciate about this topic. And to Dr. Leo, I have one question. Your study showed that this probiotic is contraindicated in preeclampsia. Is it contraindicated, or do we use it for pregnant women to prevent preeclampsia? So I'm still a little bit confused about that. So, and the second one, Dr. Leo, talking about bacterial vaginitis. So usually the gold standard, as you said just now, we use metronidazole, right? But what is the role? How significant is it if we combine metronidazole with probiotic in in treating this case of bacterial? So, and then sometimes the ladies, they come with leukorrhea. It's not always bacterial. So it could be leukorrhea due to hormonal imbalance, I think, right? So do you think that we don't need antibiotic, but we just give probiotic? What do you think about that? Thank you. That's all.
Ya, terima kasih Dr. Surjit. Jadi saya jelaskan dalam bahasa Indonesia saja, saya kira, supaya anak-anak kita juga bisa menangkap. Jadi studi itu tidak kepada preeklamsia. Jadi bukan probiotik diberikan untuk mencegah preeklamsia. Tetapi ada studi tadi itu kebetulan pada kelompok yang menderita diabetes gestasional. Diberikan probiotik, untuk diabetesnya itu ternyata efeknya tadi itu positif. Tadi yang sudah kita sebutkan itu, yang hiperbilirubinemia dan sebagainya. Tetapi ketika diperiksa tekanan darahnya, ada peningkatan pada sebagian yang dapat probiotik dibandingkan dengan yang tidak dapat, ya, yang placebo group itu lebih tinggi persentase yang hipertensi dibanding yang placebo. Oleh karena itu, di sini poinnya adalah kalau kita berikan probiotik kepada wanita hamil, hati-hati bisa terjadi peningkatan tekanan darah, jadi bukan preeklamsia. Itu saya kira. Kemudian yang berikut tadi masalah leukorrhea, ya. Leukorrhea ya, itu macam-macam. Tadi ada 3 tipenya yang utama. Adalah bacterial vaginosis, kemudian candidiasis, kemudian trichomoniasis. Jadi secara klinis sebenarnya kita bisa, ya, mahasiswa pun ini kan kompetensinya 4 ini. Harus tahu, jadi bisa kita bedakan yang mana candidiasis, yang mana bacterial vaginosis, yang mana trichomoniasis. Itu mahasiswa kita sudah hafal itu, Dr. Surjit. Oleh karena itu, terapilah sesuai dengan penyebabnya. Nah, pada orang tua memang ada juga itu, vaginitis senilis itu, jadi hormon. Kita berikan juga memang estrogen, biasanya ada preparat kita yang salap itu, estrogen itu, dan itu akan memperbaiki mukosa vagina sehingga nanti suasana normal flora itu bisa kembali setelah pemberian hormon. Ya, saya kira itu, Dr. Surjit. Ya, terima kasih.
Terima kasih, Dr. Leo. Before we close the symposium session, we want to get a closing statement from Prof. Endang and Prof. Hegar. Please.
Ini bukan closing statement ya, tetapi ini penambahan pengetahuan ini bagi adik-adik calon dokter maupun para dokter ya. Jadi jangan disalahartikan bahwa probiotik itu sebagai obat ya. Probiotik itu adalah suplemen. Probiotik sebagai obat itu memang evidence-nya sampai saat ini belum terlalu kuat. Nah, di dalam paper yang kami terbitkan itu ada probiotik untuk menangani diabetes maupun obesitas. Namun perlu diingat bahwa penelitian yang kami lakukan untuk penderita diabetes pun itu tetap harus mengonsumsi obat reguler. Probiotik tidak digunakan untuk menggantikan obat reguler, ya, tetapi digunakan untuk mendampingi ya anak-anak stunting ya yang juga menjadi responden penelitian kami itu juga tetap harus dipenuhi kebutuhan gizinya. Probiotik itu tidak menambah gizi, probiotik hanya menyehatkan usus untuk mengurangi gejala-gejala penyakit yang lainnya. Jadi di mana usus sehat ya, tubuh juga akan sehat. Makanya pesan terakhir, jaga ususmu agar sehat tubuhmu.
Baik, thank you, Prof. Next, Prof. Hegar, please. Prof. Hegar. Ya.
Bahwa kita tahu bahwa data-data terkait probiotik dihubungkan dengan gut health itu semakin banyak datanya juga memberikan promising pada kita semua. Tapi jangan lupa bahwa sesuatu penelitian pada probiotik makhluk hidup yang dilakukan pada makhluk hidup juga hasilnya sering sekali memberikan data yang sangat berbeda dengan yang kita harapkan. Kemudian adalah yang jangan lupa adalah strain spesifik. Artinya satu strain tertentu untuk spesifik kondisi tertentu. Sehingga kalau bila kita memberikan suplementasi probiotik kepada satu kondisi harus based on good quality data yang ada di publikasi. Ya, artinya ini menjadi sangat hal penting. Bagaimana kita cara mengimplementasikan kepada pasien kita? Satu, kita lihat guideline. Kalau tidak ada guideline bisa lihat rekomendasi. Kalau tidak ada rekomendasi bisa kita lihat apabila ada 3 atau sampai 5 data yang sama, penelitian yang sama memberikan hasil yang cukup sama bagusnya terhadap satu kondisi, mungkin bisa pertimbangkan kita berikan kepada pasien-pasien kita. Itu saja mungkin dari saya saat kita menggunakan probiotik ini dengan rasional, cost efektif, dan based on quality evidence. Makasih banyak.
This symposium, I hope you enjoyed this session and I look forward to your participation in future symposium. Saya kembalikan kepada MC, Dr. Christine. Applause.
Thank you, Professor Endang Sutriswati Rahayu, Professor Badriul Hegar, and Mr. Leo Simanjuntak for all the informative and insightful presentation and discussion, and Mr. Srunggura Pitupulu as our moderator. We continue to our last symposium session from Mrs. Helena Rugunenggolan, Mrs. Tambar Kembaran, Professor Sarma Lumban Raja, who will be led by our moderator, Mr. Marwata Silalahi. Mr. Marwata Silalahi, time and place are yours.
Thank you, Dr. Christine. Ladies and gentlemen, now we have come to the last symposium in our event, but the symposium not the least. So our topic is very important because the problem of HIV is one of national program in health problem in our country. So supaya ini bisa kita pahami, maka dalam presentasi dan diskusi nanti kita bisa lakukan dalam bahasa Indonesia. Sebagai pembicara pertama, ini adalah Dr. Helena Rugun. Beliau adalah Kepala Bidang Kesehatan Masyarakat di Dinas Kesehatan Kota Medan. Beliau, Dr. Helena Rugun, menyelesaikan pendidikan dokternya dari Fakultas Kedokteran USU, dan kemudian terakhir adalah S2 Magister Kedokteran Tropis. Beliau sudah mengikuti beberapa pelatihan di dalam fungsional, dan pada saat ini berhubung karena Dr. Helena Rugun tidak bisa hadir bersama kita, maka beliau akan menyampaikan pemaparan presentasinya secara online. Kepada Dr. Helena Rugun, kami persilahkan.
Selamat siang, salam sejahtera bagi kita semua. Izinkan saya share screen, topiknya epidemiologi of HIV. Apakah sudah terlihat?
Sudah terlihat, Dr. Helena.
Oke, baiklah, topik yang saya bicarakan tentang epidemiologi HIV dan mungkin lebih spesifiknya untuk kondisi HIV dan AIDS di Provinsi Sumatera Utara. Nah, mungkin sekedar untuk refreshing, tonggak awal sejarah HIV AIDS yang pertama sekali itu dari, kita ingat dari simian imunodefisiensi virus, yaitu sejenis retrovirus yang ditemukan pada primata berasal dari Afrika, di mana penularan pertama SIV HIV itu mungkin sekitar tahun 1920. Sejak itu pandemi HIV merebak di Kinshasa, Republik Demokratik Kongo Afrika, kemudian menyebar lewat pekerjaan imigran dan perdagangan seks. Dan di tahun 1960, HIV menyebar dari Afrika ke Haiti dan Karibia, dan tahun 1970 diperkirakan HIV masuk ke Amerika Serikat dan menyebar ke seluruh dunia. Sedangkan di tahun 1984, peneliti mengidentifikasi penyebab HIV/AIDS itu ternyata berasal dari HIV. Sejak itulah tes HIV/AIDS mulai dilakukan, dan kalau kita ingat mungkin di tahun 1985 itu ada suatu aktor yang tersohor yang pertama kali mengatakan bahwa dia akan menderita penyakit AIDS, dan sejak itu tercatatlah sudah ada 20.000 kasus AIDS di seluruh dunia. Di mana kita ketahui bahwa HIV ini yang disingkat dengan HIV ya, Human Immunodeficiency Virus, itu adalah virus yang menyerang sistem kekebalan tubuh yang menyebabkan penyakit imunodefisiensi sindrom atau disingkat dengan AIDS. Nah, kumpulan gejala dan tanda infeksi yang berhubungan dengan penurunan sistem kekebalan tubuh yang didapat karena infeksi HIV. Nah, sejak awal epidemik diperkirakan ada sekitar yang terinfeksi HIV itu cukup banyak ya, dan sekitar 40, dari 60 juta ada sekitar 40,4 juta orang yang meninggal karena HIV ya. Secara global itu ada 39 juta
orang yang hidup dengan HIV pada akhir tahun 2022 dan diperkirakan 0,7% orang dewasa berusia 15 sampai 49 tahun di seluruh dunia hidup dengan HIV. Meskipun beban endemi sangat besar, masih sangat bervariasi antara negara dan wilayah. Nah, di Afrika yang merupakan wilayah yang terkena dampak paling parah, itu dengan hampir 1 dari setiap 25 orang dewasa atau sekitar 3,2% hidup dengan HIV. Dari 2/3 orang yang hidup dengan HIV di seluruh dunia. Adapun situasi dan tren, pada akhir tahun 2022 diperkirakan ada 76% orang yang hidup dengan HIV mengakses terapi antiretroviral yang kemudian yang diperkirakan naik dari 24% pada tahun 2010. Dan secara global terdapat 1,2 juta perempuan hamil dengan HIV pada tahun 2022 dan diperkirakan ada sebanyak 82% menerima obat antiretroviral untuk mencegah penularan dari ibu ke anak. Dan di akhir tahun 2022 terdapat lebih kurang 1,5 juta anak yang hidup dengan HIV secara global. Diperkirakan turun dari 2,5 juta pada tahun 2010. Dan orang yang hidup dengan HIV diperkirakan ada 39 juta dengan angka kematian 630.000. Mungkin sekedar untuk refleksi, sekedar informasi saja ya, penularan HIV bisa melalui hubungan seks ataupun darah dan ibu ke bayi. Nah, hubungan seks yang tidak aman itu baik dari heteroseksual maupun dari homoseksual. Sedangkan penularan HIV dari darah itu melalui transfusi darah dan jarum suntik yang tercemar. Dan ibu ke bayi itu bisa dari pada saat kehamilan, pada saat melahirkan, dan saat menyusui. Nah, ini sekedar juga mengingatkan saja bahwa HIV itu dapat dicegah dengan ABCDE sebenarnya, berperilaku seks yang aman, tidak berbagi alat suntik, adanya screening darah donor, program pencegahan penularan HIV dari ibu ke anak, dan adanya kewaspadaan standar pada tenaga kesehatan. Dan ini perjalanan penyakit dari infeksi HIV menjadi AIDS, di mana mulai dari masuknya HIV, kemudian prosesnya bisa sampai 5-10 tahun ke depan tidak nampak. Nampaknya sehat tanpa gejala, dan adanya masa jendela itu open window period yang bisa mengakibatkan di situ masa yang paling banyak sampai akhirnya meninggal. Nah, adapun ruang lingkup pengaturan dan penanggulangan HIV, AIDS dan PMS itu untuk di dalam Permenkes yang sudah dikeluarkan di tahun 2022 itu meliputi daripada target dan strategi, promosi kesehatan, pencegahan penularan, surveillance, penanganan kasus, pencatatan dan pelaporan, tanggung jawab pemerintah pusat dan pemerintah daerah, peran serta masyarakat, penelitian, pengembangan dan inovasi, pedoman penanggulangan HIV/AIDS dan PMS maupun pendanaan dan pembinaan dan pengawasan. Nah, kalau dilihat daripada peta penyebaran kasus HIV/AIDS di dunia bisa dilihat ya di atas 1 juta itu kita lihat di daerah Amerika Serikat ya, di daerah USA dan Alaska, kemudian juga banyak di daerah South Africa, Nigeria, dan India. Sedangkan kalau kita lihat yang angkanya merah ya, yang keasirannya merah itu berkisar 500.000 sampai dengan 1 juta di daerah Brazil dan Rusia. Sedangkan untuk Indonesia sendiri itu kita lihat ya berkisar di angka 160.000 sampai 210.000. Nah, untuk penyebaran kasus HIV/AIDS di dunia ini memang kita lihat paling banyak itu di daerah asalnya, ya di Afrika Sub-Sahara. Ya, kemudian daerah lain juga meningkat secara
Nah, adapun global HIV epidemic di tahun 2022 diperkirakan dari data yang didapat pada tahun 2022 ada dilihat di sini ternyata paling banyak itu usianya di atas 15 tahun itu sekitar 37,5 juta yang orang yang hidup dengan HIV, di mana orang yang tertular dengan HIV diperkirakan sekitar 1,2 juta dan yang meninggal diperkirakan karena HIV sekitar 540.000 orang. Dan kalau dilihat pada global HIV epidemic tahun 2022 ini, nah untuk yang hidup, orang yang hidup dengan HIV pada wanita itu lebih banyak daripada laki-laki, tetapi penularan itu paling banyak, lebih banyak pada laki-laki daripada wanita, di mana wanita 540.000, sedangkan laki-laki 640.000, dan angka kematian juga ternyata lebih banyak pada laki-laki 310.000 dibandingkan dengan perempuan di atas 15 tahun sebanyak 230.000. Dan kalau kita lihat untuk anak-anak sendiri, ternyata jumlah kasus yang hidup dengan HIV sebanyak 1,5 juta, kemudian tertular sekitar 130.000 dan sampai menimbulkan kematian itu ada 84.000 kasus pada anak. Nah, ini kita lihat ya, ini sama tadi sudah diestimasi ya. Estimasi ODA orang dengan HIV/AIDS itu di tahun 2020 untuk Indonesia kita lihat angkanya ada di angka 526.841, di mana kita lihat di sini yang berwarna merah ya, 15.000 sampai 30.000 itu ternyata di daerah Sumatera Utara. Di daerah ini ya, di atas 30.000 ya. Di atas 30.000 ada Pulau Jawa dan Pulau Papua yang paling banyak. Sementara untuk Sumut itu kita lihat di angka sekitar 15.000 sampai 30.000. Nah, paling banyak itu di daerah Jawa dan di daerah Papua. Nah, kita ini Kota Medan ini Sumut sama ya dengan daerah ini Sulawesi Selatan. Nah, adapun tren infeksi HIV baru di Indonesia ini bisa kita lihat dari indeks HIV kasus-kasus barunya, ternyata ada 43% penurunan infeksi HIV baru di antara tahun 2010 sampai dengan tahun 2020. Dan kita target kita ya untuk di tahun 2030 kalau bisa targetnya di bawah daripada 16.000. Adapun target ending AIDS ya pada tahun 2030 kita berharap adanya zero new HIV infection. Jadi angka kasus baru yang terinfeksi HIV kalau bisa zero ya. Jadi orang dengan HIV mengetahui statusnya itu diharapkan bisa tercapai 95%. Dan kemudian diharapkan juga adanya zero AIDS related death ya, kematian akibat AIDS itu kalau bisa diturunkan ke angka 0. Jadi diharapkan ODIF ya, orang dengan HIV positif itu mendapatkan pengobatan ARV sebesar 95%. Kita harapkan seperti itu supaya bisa jangka waktu umurnya bisa lebih maksimal. Kemudian ODIF ya, orang dengan HIV yang mendapat obat antiretroviral akan mendapat virusnya tersupresi itu diharapkan sebesar 90%. Nah, jadi kita mengharapkan adanya zero discrimination. Nah, jadi dari tren penemuan kasus HIV di Provinsi Sumatera Utara, nah kalau kita lihat estimasi ODA nasional itu tadi sebesar 526.841 orang. Nah, di Sumatera Utara diperhitungkan sekitar 27.772 orang. Dan HIV positif Sumatera Utara dari tahun 1994 datanya yang ada sampai Februari 2023 itu jumlahnya ada 23.696 orang, dan kita ketahui ini banyak di Sumatera Utara itu fokusnya itu di Kota Medan. Nah, kalau dilihat di sini ya, untuk Kota Medan itu paling banyak. Dia ada angkanya di angka 14.000. Ini data yang saya dapat sampai dengan April 2023. Ini yang sudah ada sebanyak 14.309 kasus ya, dan menyusul itu di daerah Deli Serdang, kemudian daerah yang lainnya seperti Karo, Pematang Siantar dan seterusnya. Kalau angka di Nia Selatan ini masih 0. Ini adalah peta penyebaran. Ini gambaran yang tadi, jadi kita juga mendata ya masing-masing daerah itu, nah ternyata sama seperti ini ya. Data yang paling banyak itu adalah di Kota Medan sebanyak 14.309 sampai bulan April 2023. Nah, adapun perkembangan Provinsi Sumatera Utara menuju target tadi ya 95%. Nah, ini diharapkan adanya estimasi ODIF ya dari yang 27.772 itu dibandingkan dengan April 2023 diharapkan jumlah penemuan ODIF itu dari yang diperkirakan sebanyak 27.772 sampai April 2023 ternyata sudah mengalami peningkatan sebanyak 23.696 dan kemudian mendapat pengobatan. Nah, kalau kita lihat di tahun 2022 dengan di tahun 2023 terjadi peningkatan orang dengan HIV yang mulai dengan memakan obat retroviral dan seterusnya. Jadi diharapkan akan tersupresi ya. Jadi virusnya tersupresi mencapai untuk sampai April 2023 sudah ada peningkatan dari 21% menjadi 42%.
Waktunya 3 menit lagi, Dr. Rugun.
Oke, baiklah. Oke, untuk di tahun 2022 kalau bisa kita lihat ternyata paling banyak yang terkena dengan HIV/AIDS ini ternyata yang laki suka laki. Jadi orang yang dengan kelainan seksual ya. Kemudian seperti ini. Untuk sendiri waria, pelanggan dan untuk pengguna jarum suntik sendiri yang terdata itu sebesar 1%. Nah, ini juga distribusi kasus HIV berdasarkan faktor resiko ya. Untuk di tahun 2023 hampir sama dengan di tahun 2022. Yang paling banyak ini ternyata kaum homoseksual, laki-laki yang suka laki-laki. Bilangnya sekarang LSM. Nah, kemudian persentase hasil HIV positif di antara orang yang dites ini juga dirasakan ya. Banyak kasus ya terjadi peningkatan untuk pasangan yang unik, yang banyak itu ya pasangan yang pelanggan kerja seksual. Ternyata HIV-nya positif. Nah, kemudian berdasarkan kelompok umur juga bisa kita lihat di sini yang terbanyak kasus HIV/AIDS itu pada kasus usia produktif ya, 25 sampai 49%, baru menyusul usia 20 sampai 24%. Oke. Dan kasus HIV yang ditemukan berdasarkan kelompok umur itu tadi tahun 2022 dengan tahun 2023 sama saja, paling banyak itu di kasus 25 sampai 49% bersama. Jadi saya rasa itu saja yang bisa kita ceritakan terkait dengan kasus HIV/AIDS khususnya di Provinsi Sumatera Utara dan Kota Medan. Terima kasih, saya kembalikan kepada moderator.
Terima kasih, Dr. Helena. Beri aplaus untuk Dr. Helena. Selanjutnya kita sampai kepada pembicara kedua, yaitu Dr. Tambar Kembaren, spesialis penyakit dalam, konsultan penyakit tropis infeksi. Dr. Tambar adalah saat ini staf pengajar di FK USU dan di Rumah Sakit Haji Adam Malik Medan. Dr. Tambar tamat dari Fakultas Kedokteran USU tahun 1981, kemudian menyelesaikan pendidikan spesialis penyakit dalam tahun 1998 dan mendapatkan konsultan atau subspesialis penyakit tropik infeksi tahun 2014. Dan pada saat ini Dr. Tambar cukup banyak berkecimpung di dalam HIV, dan pada hari ini Dr. Tambar akan menyampaikan materi update in HIV management, dan mari kita mendapatkan apa yang terbaru tentang penata laksanaan HIV ini, karena seperti yang disampaikan oleh Dr. Helena tadi, angkanya masih cukup tinggi. Apalagi sekarang dengan kemajuan teknologi dan transportasi, banyak hal yang bisa terjadi di dalam peningkatannya, sehingga target-target tadi yang diharapkan 3.0 di tahun 2030 bisa kita capai. Kepada Dr. Tambar, waktu dan tempat kami persilahkan.
Terima kasih Dr. Marwatas sudah menyampaikan CV saya tadi dan sudah membuka acara ini ya. Selamat pagi para hadirin sekalian ya. Hari ini kita masuk ke sesi HIV yang sudah dimulai tadi oleh Dr. Rugun mengenai epidemiologi HIV. Sedangkan saya nanti menyampaikan bagaimana update penanganan HIV pada saat ini ya. Mungkin ada beberapa hal ya yang mungkin ada perubahan dari waktu-waktu yang lalu, di mana pada waktu yang lalu obat-obatan yang digunakan itu adalah obat-obatan yang mungkin tidak begitu poten untuk menurunkan viral load secara cepat ya, tetapi pada saat ini kita sudah mendapatkan obat, terutama kita di Indonesia ya. Kalau mungkin di luar, di Amerika mereka mungkin sudah beberapa tahun yang lalu sudah menggunakan obat-obat tersebut begitu ya. Kemudian yang kedua juga nanti mungkin mengenai pencegahan ya. Jadi pemberian obat antiretroviral yang disebut ARV itu digunakan sebagai pencegahan pada saat ini ya. Slide mungkin epidemiologi karena sudah disampaikan Dr. Rugun ya, mungkin hanya sedikit mungkin saya ini kan ya, ini outline yang akan saya sampaikan. Slide. Ya, ini tadi sudah disampaikan Dr. Rugun ya, slide. Ya. Kita lihat ya, ini apanya ya, distribusinya kalau kita lihat di Southeast Asia sekitar 3,9 juta, tapi kalau kita lihat di Afrika 25,6 juta orang yang terinfeksi HIV ya. Jadi kalau kita lihat seperti itu ya, tadi sudah disampaikan Dr. Rukun juga ya, sehingga penelitian yang dilakukan oleh WHO itu kebanyakan di Afrika ya. Jadi kalau ada obat-obat baru juga mereka melakukan penelitian di sana. Sehingga nanti dapat kita lihat nanti di slide saya bahwa tadi tujuan untuk mencapai zero new infection ya ataupun eliminasi HIV di 2030, mereka sudah sangat maju seperti itu dibandingkan kita di Indonesia di mana data kita sangat minim. Slide. Nah, ini insidence dan mortalitasnya ya. Lanjut. Ini 2010 ya, coba slide yang tadi. Ya 2010, ini di 2000. Ini ya. Oke, slide. Nah, ini kita lihat terjadi penurunan sebetulnya ya. Baik kematian maupun infeksi baru HIV ya. Akibat kemajuan tadi adanya obat-obatan dan juga program-program untuk pencegahan infeksi HIV. Slide. Nah, ini juga tadi ya, infeksi baru pada wilayah-wilayah ya di 2020 dan 2022. Kalau ini slide-nya agak sedikit kabur ya, tapi kalau kita lihat di sini di semua wilayah itu terjadi penurunan infeksi baru ya. Slide. Nah, ini tadi sudah disebutkan Dr. Rugun ya bahwa untuk tercapainya tadi eliminasi infeksi HIV di 2030, maka semua pasien yang diestimasi terinfeksi HIV itu minimal itu tercapai minimal 95% itu dilakukan tes. Kemudian yang dilakukan tes itu 95% mendapatkan obat antiretroviral. 95% yang mendapatkan antiretroviral itu tersupresi viral load-nya, artinya tidak terdeteksi di dalam darahnya. Ya, jadi kalau tersupresi virus di dalam darah itu menyebabkan tidak lagi menginfeksi orang lain, gitu ya. Jadi tidak lagi menginfeksi orang lain. Itu pentingnya semua pasien HIV harus mendapatkan ARV. Kalau bisa hari ini tes, hari ini juga diberikan ARV supaya secepat mungkin viral load-nya tersupresi, ya. Oke, lanjut. Oh, tidak terlihat. Ini di Thailand ya. Slide yang tadi. Nah, ini di Ethiopia ya. Saya sebutkan di Afrika ya. Nanti dibandingkan dengan di Indonesia ya. Nah, ini di Ethiopia, ini dia mereka hasilnya. Ini dan ini ya. Slide. Ini di Thailand ya. Saat ini dia sudah 94% ya. Saat ini yang mendapatkan ARV, ini yang viral load-nya tersupresi. Nah, slide berikutnya. Nah, ini Indonesia. Tidak ada data. Kita yang hanya people living with HIV receiving ART. Jadi cuman 153.000 ya orang yang mendapatkan ARV ya, sekitar 28%. Kita bandingkan dengan mereka tadi sudah di atas 80% ya. Jadi nanti adik-adik juga ya supaya pada waktu nanti sudah sudah bekerja supaya mengetahui apa yang menjadi tugas kita sebagai dokter, sebagai petugas kesehatan ya untuk mengurangi transmisi dari infeksi HIV tersebut ya. Lanjut. Nah, ini ya gejala klinis ya. Ini gejala klinis infeksi akut ya. Sebetulnya ya orang yang terinfeksi HIV itu pada saat dia terinfeksi dia sebetulnya mempunyai gejala walaupun ada juga yang tidak ya. Dia seperti flu-like syndrome ya, demam ya, bisa juga sama-sama dengan seperti COVID ya. Pada kita sudah merasakan semuanya ya. Jadi hilang nafsu makan gitu ya. Kemudian adanya mungkin rash ya. Kemudian ada batuk gitu ya. Nah, kemudian fatigue ya, ini kalau tidak salah saya ini penelitian di China, ini penelitian di Thailand ya. Jadi ini gejala-gejalanya pada saat akut infeksi gitu ya, walaupun ada yang tidak jelas gejala-gejalanya gitu ya. Lanjut. Nah ini kalau sudah masuk ke mempunyai gejala klinis, dia ada 4 stadium ya, stadium 1, 2, 3, 4 ya. Stadium 1 itu biasanya tidak ada gejala. Jadi sesudah akut infection tadi, gejala klinis yang itu mungkin sekitar 2-3 minggu, kemudian pasien itu tidak ada gejala ya, sampai dia nanti muncul ke stadium 2 ya. Di stadium 2 di sini sering sekali kita miss ya sebagai dokter. Kadang di sini pasien sudah datang dengan dermatitis seborrheic yang berulang, tidak ada diobatin tidak sembuh gitu ya. Kita tidak aware ke arah sana. Saya punya pasien yang dia menderita penyakit kulit ya, sudah berobat sekitar 3-4 tahun ya. Karena dia kebetulan pegawai di salah satu institusi, pindah dari Indonesia Timur, kemudian akhirnya dia pindah ke Sumatera Barat. Nah, sesudah dia mempunyai gejala mata kabur ya, yang otomatis stadium 4 ya, di situ baru ketahuan dites HIV-nya. Padahal seharusnya kalau dia dites di stadium 2 ini sangat membantu pasien. Kenapa? Dia akan segera tadi imunitasnya pulih karena pemberian obat ARV dan kualitas hidupnya akan baik. Ya, daripada dia sudah stadium 4 ya, sudah ada tokso, ada meningitis ya, ada PCP ya, yang semuanya itu penyakit-penyakit berat yang mengancam jiwa ya. Sehingga angka kematian juga bisa jauh diturunkan kalau kita masih mendapatkan di stadium 2. Ya, apalagi tadi di stadium 1 ya. Nah ini kita lihat ya, tadi berat badan sudah mulai menurun, tidak jelas, ada herpes ya, angular cheilitis ya. Kemudian ini infeksi jamur barangkali di kuku ya, ini papular pruritic eruption. Nah pasien saya itu inilah yang dia alami, papular pruritic eruption. Udah berobat ke dokter kulit tetapi karena tidak dilakukan tes, akhirnya dia jatuh ke CMV retinitis dan pasiennya buta ya. Nah, dia hidup sampai sekarang masih hidup tapi pasiennya jadi buta, jadi kualitas hidupnya jadi terganggu. Slide. Ini stadium 3 ya. Di sini sudah berat badannya ini ya, lebih dari 10% ya. Kemudian ada oral candidiasis, biasanya itu yang sering kita lihat ya, mungkin tuberkulosis ya. Dan gejala-gejala yang lain lagi sudah dijumpai, barangkali anemia ya, yang tidak tahu apa penyebabnya gitu ya. Terjadi juga trombositopeni ya. Slide. Nah ini stadium 4. Nah di rumah sakit Adam Malik yang kami dapatkan adalah stadium 4 dan stadium 3 ya. Karena di sana rumah sakit rujukan. Sebetulnya yang tadi semua stadium 2 atau 1 itu didapatkan harusnya di puskesmas ya. Jadi kalau ini udah semua udah ada keganasannya, sarkoma kaposi ya, kemudian ada nanti mungkin sudah yang berat-berat semuanya ya. Wasting syndrome ya. Kemudian ada limfoma ya. Dan semuanya sudah yang berat-berat, toksoplasma ya, kemudian Cryptococcus meningitis gitu ya. Jadi pasien mungkin datang sudah dengan kejang-kejang seperti itu ya. Oke, slide. Nah untuk menegakkan diagnosis ya, itu biasanya dengan pemeriksaan antibodi 3 metode ya, dengan 3 metode yang berbeda. Ya, jadi diperiksa metode 1 yang sensitivitasnya sangat tinggi ya, 99%, kemudian diikuti tes yang kedua dan diikuti oleh tes yang ketiga ya. Jadi kalau 3-tiganya itu positif baru kita nyatakan positif ya. Kalau kita lihat di sini ya, kalau di tes pertama dia negatif ya, maka kita nyatakan dia negatif ya. Kemudian kita tes yang kedua ya, tes yang kedua kalau dia reaktif ya, dilanjutkan dengan tes yang ketiga ya. Nah kalau ketiga-tiganya dia reaktif, baru kita nyatakan dia itu positif terinfeksi HIV. Jadi kalau nanti kalian nanti mendeteksi misalnya baru R1 positif, ya jangan langsung diberitahu bahwa pasiennya itu kamu positif HIV, ya ada standarnya, ya karena bisa yang tes yang positif itu ternyata sesudah dilakukan tes berikutnya ternyata negatif. Jadi sangat ketat syaratnya untuk kita menegakkan diagnosis HIV berdasarkan antibodi. Kecuali kita memeriksa virusnya, ya. Kalau kita memeriksa virusnya dengan pemeriksaan PCR, kalau itu positif ya terus kita nyatakan positif. Misalnya nanti yang disampaikan Prof. Sarma, ya pada bayi baru lahir, ya. Karena antibodinya masih ada dari ibu, ya itu kita lakukan pemeriksaan dengan PCR, ya. Nah, kalau misalnya tadi tes pertama reaktif, tes kedua reaktif, tes ketiga non reaktif, maka itu kita ulang 2 minggu lagi, ya kita ulang 2 minggu lagi, baru dinyatakan positif kalau ketiga-tiganya positif. Kalau nanti misalnya akhirnya negatif, maka kita nyatakan negatif terhadap pasien tersebut, ya. Lanjut,
Izin
slide.
Dokter tambah waktunya 3 menit lagi.
Oh iya. Nah, ini pedoman Indonesia memulai ARV, ya. Kita lihat di sini dulu ya 2004 CD4 di bawah 200 baru diberikan obat ARV. Kemudian tahun 2006 di bawah 350, kemudian di bawah 350, tapi saat ini ya 2019 semua pasien HIV positif diberikan ARV. Karena tadi tujuannya untuk mencegah penularan terutama, ya, selain untuk memperbaiki kualitas hidup, kemudian juga memperpanjang survival gitu, ya. Lanjut slide. Nah ini sekarang regimennya, ya pada dewasa, ya kita lihat dia menggunakan dolutegravir, ini tenofovir, lamivudin. Jadi ini simbol-simbol obat-obat ini sudah secara simbol secara internasional, ya. Jadi kita tidak perlu lagi kalau begini pasti tenofovir, ya. Ini lamivudin, tritisi, ya. Dan ini M3-citabin, ini dolutegravir, ya. Jadi ini sekarang regimennya. Kalau dulu ini regimen pertama, ya. Ini regimen pertama. Kalau dia gagal terapi baru dilanjutkan dengan menggunakan ini ya, ritonavir, lopinavir, ya. Tapi sekarang ini, kenapa ini digunakan? Karena ini dolutegravir, golongan integrase inhibitor, ini merupakan ARV yang sangat poten kalau dikombinasikan dengan ini. Kalau kita lihat pasien-pasien yang mendapatkan obat antiretroviral, ya, katanya 6 bulan itu bisa tidak terdeteksi lagi viral load-nya, ya. Jadi virusnya bisa tidak terdeteksi sesudah memakan obat ini 6 bulan. Tapi dengan menggunakan dolutegravir, beberapa pasien itu 1 bulan pun dia bisa tidak terdeteksi lagi, gitu ya. Jadi sehingga pemerintahan kita ya ini guideline WHO tapi diadopsi juga oleh pemerintah Indonesia. Jadi pedoman kita di Kemenkes juga menggunakan ini, ya. Atau digunakan ini, ya, efavirenz 400 mg karena yang 600 mg mempunyai efek samping. Atau digunakan yang 600 mg ya, tetapi mempunyai efek samping, atau yang berikutnya di bawah ini, ya. Slide. Ini untuk lini kedua. Jadi dia gagal lini pertama masuk ke lini kedua. Gagal lini kedua masuk ke lini ketiga, ya. Ini lini kedua, ya. Jadi kalau kita lihat di sini, ya, kalau dia gagal dengan lini pertama menggunakan dolutegravir, maka digunakan ini lopinavir, ritonavir, di mana obat ini juga waktu itu digunakan untuk obat COVID, ya, pada awal-awal kemarin, ya, obat HIV ini kita gunakan juga untuk pengobatan COVID, ya, atau ini darunavir, ritonavir, ya. Tapi kalau dia tadi menggunakan efavirenz masih pada lini pertama, maka lini keduanya bisa menggunakan dolutegravir. Slide. Nah ini post exposure prophylaxis. Ini pada pasien-pasien yang terpajan, ini ya terpajan karena tertusuk jarum ya, yang petugas kesehatan. Baru-baru ini juga saya punya ada petugas kesehatan di Rumah Sakit Adam Malik yang tertusuk, baru dia menganestesi, dia tertusuk. Ini segera kita berikan ya, kalau bisa di bawah 4 jam ya, supaya dia tidak terjadi infeksi. Ya, segera kita berikan ini ya. Jadi kalau nanti kalian sedang bertugas tertusuk, segera lapor pada waktu itu juga ya, sehingga pada waktu itu nanti diberikan langsung obat ini. Ini pilihannya ya, alternatifnya yang di bawah. Slide.
Waktunya sudah habis, Dokter Tambar.
Ini ada PrEP, mungkin sedikit ya. PrEP ini ya, ini pre-exposure prophylaxis ya. Pre-exposure ini yang sasarannya adalah ini ya. Laki-laki, LSL ya, WPS ya, waria transgender ya, pengguna narkotika suntik ya, seseorang yang memiliki pasangan seksual dengan status HIV positif. Ini PrEP ya. Jadi PrEP ini pada orang yang belum terinfeksi ya, diberikan obat ini. Jadi ARV diberikan pada orang yang berperilaku akan mendapatkan infeksi ya. Lanjut slide. Nah ini dia obatnya, 2 obat ya. Slide. Nah ini dimakan ya, 2 pil pertama, kemudian 1 pil 24 jam kemudian gitu ya. Ada juga yang setiap hari untuk 7 hari. Jadi dia nanti untuk LSL atau selain LSL tadi ya. Slide. Nah ini pemberian cotrimoxazole, semua pasien HIV itu diberikan cotrimoxazole ya. Kalau dia stadium 3 dan 4 atau kadar CD4-nya di bawah 200. Slide. Nah ada juga INH prophylaxis. Slide. Nah ini ada interaksi obat ya. Jadi interaksi obat ini perlu dipikirkan pada pasien-pasien HIV yang mendapatkan obat antiretroviral. Nanti kita kira obatnya yang tidak efektif, ternyata ada dia obat yang membuat kerjanya tidak efektif. Ya, barangkali ini yang bisa saya sampaikan. Terima kasih.
Terima kasih Dokter Tambar, presentasi yang sangat menarik. Nah, tadi ini kita dapat masukan itu. Ternyata Indonesia nggak banyak datanya dari Dokter Tambar. Ini kepada adik-adik mahasiswa yang mungkin mau melaksanakan KTI, ini banyak peluang ini untuk penelitiannya di bidang HIV. Nah itu ya. Jadi terima kasih Dokter Tambar dan masukannya. Ini ternyata Dokter Tambar bilang bisa dikerjakan di puskesmas beberapa hal. Selanjutnya, untuk pembicara yang berikutnya, kita akan sampai kepada Prof. Sarma dengan topik HIV in pregnancy. Prof. Sarma adalah guru kita yang saat ini bertugas sebagai staf pengajar di FK USU dan juga di Rumah Sakit Adam Malik. Prof. Sarma sudah cukup banyak berkecimpung di dalam penelitian dan juga sudah menjadi penulis beberapa artikel ilmiah yang sudah dipublikasi dan terakreditasi internasional. Prof. Sarma juga terlibat di dalam beberapa kebijakan yang untuk bidang-bidang yang berhubungan dengan bidang obstetri dan ginekologi dan juga sudah memperoleh HKI di dalam beberapa judul buku beliau, dan Prof. Sarma akan menyampaikan seperti tadi, yaitu HIV pada kehamilan atau HIV in pregnancy. Waktu dan tempat kami persilakan kepada Prof. Sarma.
Terima kasih kepada Dr. Marwatas sebagai moderator pada sesi yang terakhir. Mudah-mudahan belum bosan. Yang saya hormati Pak Dekan, yang dari Ibu dari Prof dari Yogyakarta ya. Semua teman-teman saya di sini dan yang saya kesayangi semua mahasiswa. Kalau tadi sudah epidemiologi sudah, cara mendiagnosis sudah, ini saya ambil yang kecil aja. Ibu hamil, bersalin, nifas dan bayi yang dilahirkannya. Slide. Oh ya nggak bisa ini. Jadi ini tentang ibu hamilnya aja nih, hamil, bersalin dan nifas. Next. Lanjut. Nah, kalau ini tadi udah dibicarakan, kapan dijumpai. Saya hanya mau bilang bahwa HIV yang diceritakan tadi, yang wajib dilakukan pemeriksaannya di puskesmas, ini nanti mau ke puskesmas ini. Kalau kita ingat sekarang antenatal care kita itu kan 6 kali kunjungan minimal. Kunjungan pertama maunya trimester 1. Tetapi kalau nanti anak-anak kita bilang ya, anak-anak kami yang banyak saya lihat ini ke sana ke puskesmas, kalau nggak datang trimester 1 jangan terus bilang nggak usah periksa lagi lah. Dia kan udah trimester berikut, udah kunjungan berikut, tetap kita lakukan seperti kunjungan pertama. Kenapa? Karena pada ibu hamil ini agak lucu. Lucunya apa? Bukan lucu ya. Yang mau kita hindarkan adalah jangan sampai nular lah sama anaknya. Kalau enggak nular apalagi supaya ibunya sehat selama hamil, bersalin dan nifas. Anak yang dilahirkannya pun nanti keren, enggak tertular. Kayak kata dokter Tambar tadi, kalau kita dapati dia masih trimester 1, mudah-mudahan gak kena ke anaknya. Karena kita tahu bahwa kalau ibu hamil tidak dilakukan intervensi terhadap HIV-nya, 45% kurang lebih anaknya tertular. Tetapi kalau kita lakukan tindakan, kita lakukan kasih ARV, bersalin yang aman, apalagi viral load-nya gak terdeteksi lagi, kurang dari 2% cuman penularan kepada bayinya. Next. Nah, ini saya pikir sama-sama udah tahu ini. Kita ya, HIV-nya ada berapa serotype, macam-macam ini. Bagaimana dia menginfeksi kita. Ya, virusnya masuk ke kita, replikasi dan menurunkan daya tahan kita. CD4 kita akan turun. Next. Lanjut Pak. Nah, ini yang perlu mau kita ini kan ke masyarakat nanti yang teman sejawat jumpai. Jangan terlalu takut dan jangan terlalu berani juga. Karena banyak rumors, kalau misalnya nanti aku udah HIV, takutlah nanti menular ini itu. Banyak cerita orang. Rumors ini harus kita edukasi masyarakat apa-apa aja yang bisa menularkan. Dari mana transmisinya? Harus dari cairan tubuh. Apa-apa itu? Ini dia. Jadi nggak usah takut, ada yang bilang salaman pun nggak mau lagi dia. Dokter Tambar ini salaman terus ini sama pasien HIV. Mudah-mudahan nggak ada dia kena. Kita juga mengoperasi pasien HIV. Nah, jadi kalau kita tidak bersentuhan dengan cairan tubuhnya, mudah-mudahan kita nggak tertular, tidak akan tertular dengan HIV. Next. Tadi kata Dokter Tambar, saya tadi sempat diskusi 95. Terdeteksi 95%, yang 95% terdeteksi. 95% dapat ARV, 95% turun viral load-nya. Ini yang gak dapat kita. Kalau kita lihat ini sampai 2022 yang kita dapat segini ibu hamil hanya sekian yang terscreening. Saya berani bilang ini, kenapa? Kita buat penelitian dari 1000 ibu hamil yang kita ini gak ada yang diperiksa. Di Kota Medan saya buat berapa ibu hamil, cuman 1 yang diperiksa. Jadi data ini akhirnya, mana tadi dia? Belum. Setelah. Kemudian next. Nah ini, percayalah kita ini. Kapan mau dapat segitu? Entah kapan mau dapat, karena segini ibu hamil, jadi buku KIA kita yang pink itu dicetak oleh Kemenkes kira-kira sekian. jumlahnya, 5 juta kurang lebih. Jadi jangan bilang nggak cukup bukunya, cukup. Ya, dicetak segitu karena kurang lebih segini ibu hamil kita. Cuma seginilah bayi yang terobati. Padahal tadi katanya tahun 2030 ya mau 0 penularan. 0 penularan artinya 0 lah bayi yang baru lahir sakit. Ya, 0, tidak ada lagi bayi yang baru lahir terinfeksi dari ibu yang mengandungnya. Next. Lanjut Bang. Nah, bagaimana kita melakukan prevensinya? Prevensinya maunya jangan ada lagi ibu usia reproduksi yang kena HIV. Kalau mau hamil direncanakan dulu. Jangan bilang misalnya dia HIV, aku gak mau nikah sama dia. Cinta udah ke ubun-ubun, boleh nikah, boleh. Boleh hamil, boleh, tapi kita rencanakan. Rencanakan kayak apa? Kasih ARV sampai tak terdeteksi lagi nantinya. Jadi bisa dia berhubungan seks sama pasangannya, bisa. Kalau udah hamil, kita kasihlah ARV pada ibunya. Kalau nanti ini sebagai prong kalau pelajaran kita ini harus kita support ibunya, bayinya dan keluarganya. Ini keluarganya kasihan ini, apalagi misalnya ibunya meninggal, anak ini nggak ada yang mau pelihara. Perlu kita edukasi supaya ada yang memelihara dia. Next. Stadium-stadium tadi dokter Tambar udah, lanjut. Nah, bagaimana transmisi dari ibu ke anak yang dikandungnya? Ini dia, transplasenta. Makanya kalau dibilang nggak ada campur darah ibu sama darah bayi, ada mikrotransfusi. Makanya perlu kita berikan, ayo kita berikan ARV untuk mencegah nomor 1, nomor 2. Demikian juga yang ini, ascending infection. Seolah-olah katanya dari sekret yang di bawah bisa menembus plasenta katanya. Baru yang berikut, ya langsunglah. Apa sumber-sumber? Cairan yang tadi. Bagaimana rutenya? Ini rutenya, ini yang saya sebutkan tadi. Kalau kita lakukan intervensi yang keren, mudah-mudahan ini bisa kita hindarkan semuanya, penularannya. Next. Bagaimana strategi untuk prevensinya? Sama yang ke-4 tadi, 4 langkah tadi, turunkan hamil dengan HIV pakai kontrasepsi tentunya. Kalau udah hamil kita kasih ARV. Model persalinannya, bagaimana seksio, ini jadi masalah sekarang, angka seksio kita tinggi, jadi jangan berpikir seksio sesaria, HIV harus di seksio, enggak juga. Kalau kita lakukan tadi pemeriksaan HIV-nya trimester 1, disebutkan bahwa 6 bulan makan ARV, virusnya enggak terdeteksi lagi. Trimester 1 kan kurang lebih 3 bulan ke bawah, 6 bulan lagi dia baru lahiran. Udah bisa pervaginam? Bisa. Karena disebutkan berdasarkan penelitian viral load-nya itu udah tak terdeteksi lagi. Makanya angka seksionya bisa kita turunkan. Kemudian untuk meningkatkan kualitas hidup ibu dan bayi yang dilahirkan tetap pakai ARV ataupun kita observasi bayinya ke depannya. Next. Nah, bagaimana dengan screening? Kalau rekomendasi mereka disebutkan kalau prevalensinya di atas 5% wajib katanya. Kalau di bawah 5% ya wajib juga. Tetapi tidak menjadi keharusan, dilakukan dengan gabung sama yang lain. Kita kayaknya nggak pakai ini, kita pakai semua. Biarpun prevalensinya berapa, semua ibu hamil wajib dilakukan screening yang kita bilang triple eliminasi di buku KIA kita itu. HIV, hepatitis dan sifilis. Lanjut, next. Nah, jadi ini yang jadi masalah ini. Kadang-kadang gak mau dia dites. Ini tadi saya tanya sama dokter Tambar, kayak mana ya kalau gak mau dites? Banyak ini gak mau. Disitulah kepiawaian kita melakukan edukasi sampai dia mau. Kalau nggak mau juga, ya kita ulang lagi sampai sekian. Ataupun saat persalinan. Dan satu lagi yang mau kita ingat, kalau udah kita tes ini, jangan hanya mau tahu positif negatif aja, reaktif non reaktif. Kelanjutannya harus kita kasih tahu. Kelanjutannya harus kita lakukan. Untuk apa tadi? Mencegah tadi sampai kita dapat zero new infection. Next. Nah, ini tadi kenapa perlu awal diperiksa langsung diobati, mau menghindarkan transmisi tadi. Ini yang mau kita inikan. Selain transmisi, apalagi kualitas hidupnya nanti juga akan lebih baik. Next. Lanjut Bang. Apa rupanya dampaknya ini HIV ini pada kehamilan? Ya banyaklah terhadap kehamilannya sendiri. Abortus, lahir mati, banyak ini yang terjadi ini. IUGR sampai chorioamnionitis. Makanya kalau orang HIV yang belum cukup syarat untuk dilakukan persalinan pervaginam, kita bilang dia kamu diseksio hamil 38 minggu ya, kan gitu. Kalau sebenarnya seksio sesaria elektif itu 39 minggu. Tapi khusus untuk HIV ini WHO itu bilang 38 ya. Kenapa? Karena infeksi itu suka cepat, pecah ketubannya lebih cepat. Saya nggak tahu hubungannya nanti dengan apa tadi probiotik ya. Jadi pecah ketubannya lebih cepat sehingga kita bilang jangan sampai dululah ke 39, 38 aja. Supaya jangan sampai pecah ketuban. Kalau pecah ketuban, infeksi pada anak lumayan cepat dapatnya. Udah kita kasih tadi macam-macam, pecah ketuban, infeksi pada anaknya dapat terjadi dengan segera. Selain keadaan pada anak, pada ibu tadi pun macam-macam bisa terjadi. Tadi sudah diterangkan oleh Dokter Tambar apa-apa yang ini tadi ya. Sehingga ada satu hal yang mau kita ingat lagi bahwa jangan takut kita, bahwa katanya gini, kok aku hamil makan ARV tapi CD4-ku kok turun ya. Jangan takut, nanti habis postpartum itu akan naik kembali, mungkin berkaitan dengan hemodilusi, pengenceran dan kembali lagi nanti setelah partus kan cairan itu akan banyak dikeluarkan. Next, lanjut Bang, nanti habis waktu. Bagaimana dengan prekonsepsi konseling? Tadi kita bilang kan, jangan usia subur, jangan ada yang kena HIV. Kalau ada kena HIV mau hamil, ayo kita lakukan asuhan prakonsepsi. Pemerintah kita udah buat simple-simple ini, asuhan prakonsepsi. Perlu nggak? Perlu. Supaya tahu kita obat apa sekarang yang dimakannya. Bisa nggak itu nanti ke depan? Kayak mana dia? Teratur nggak makannya dia? Itu ya. Supaya apa? Supaya bagus nantinya. Kita harus menjelaskan kepada ibu ini yang mau hamil ini bahwa dengan ARV itulah yang paling mungkin untuk mencegah transmisi ke bayi yang dikandungnya, yang akan dikandungnya nanti. Next.
3 menit lagi Pak.
Bang, iya. Diagnosis udah tadi cepatan, ayo. Diagnosis mau yang cepat tadi, mau yang ELISA. Ini ELISA ini ada Dokter Tambar sini, jadi ciut saya. Diagnostiknya positif, kalau negatif perlu periksa ulang lagi. Perlu lagi ke pemeriksaan lanjutan. Lanjut. Saya nggak tahu Western blot dilakukan di Adamali kita ya Kak ya. Sekarang nggak lagi, agak mahal ini ya, makanya nggak dilakukan. Lanjut. Ini untuk viral loadnya, lanjut. Nah, jadi saya apakan aja lah ini. Ini lihat nanti di buku-buku apa kita ada ini. Bagaimana algoritma untuk memeriksa ibu ini positif atau negatif. Sampai nanti dapat kita untuk melakukan terapi. Di semua puskesmas di Indonesia tes itu ada. Kitanya yang gak mau memakai. Ya, ada semua tes itu. Obatnya juga ada obatnya. Lanjut. Ini juga algoritmanya, ini macam-macam ini interpretasinya. Lanjut. Nah, bagaimana kita memonitoring. Kalau udah kita kasih obat nanti ada monitornya. Monitornya ini saya nggak tahu dilakukan apa enggak ini. Kalau di puskesmas Dokter Tambar gimana melakukan ini? Saya nggak tahu ini. Periksa ini, ya ini cerita idealnya. Saya nggak tahu kalau pelaksanaannya ada atau tidak. Lanjut untuk monitoringnya. Jadi macam-macam monitoring dan apa yang dimonitor jangan lupa karena ini banyak diekskresi melalui hepar dan renal, kita lihatlah semuanya fungsi hati dan fungsi fungsi hati dan fungsi ginjal katanya ya bulan ini periksa CD4 dan seterusnya. Walaupun CD4-nya misalnya mau melahirkan kita bilang lebih dari 350, diperiksa lagi dia. CD4-nya kita mau melihat bagaimana keadaan ibu tersebut. Lanjut, saya lihat ke dokter Marwatas padahal di belakang. Jadi monitoring itu kita lihat selain genotype kita nggak lakukan. Genotype untuk apa? Untuk lihat ada nggak resistensi. Saya pikir nggak ada ya untuk melihat resistensinya. Ultrasonografi kita lakukan. Karena pemerintah kita buat ultrasonografi ibu hamil 2 kali. Kunjungan 1 dan kunjungan 5. Wajib dilakukan. Ini mungkin tergantung dari guideline ini yang mungkin enggak. Fetal ya NIPT. Boleh kita tawarkan? Bolehlah NIPT. Ya lanjut. Antiretroviral ini kan kita lihat ada yang 2, ada yang 3 ini ya. Ya, kita mau lihat ini tapi jangan lupa tetap menghitung ini. Maksudnya gini. Kalau dulu perjalanan hidupnya ini dulu kan gini. Kasih ARV kalau usia kehamilan di atas 13 minggu. Kalau CD4 di atas 200. Tapi sekarang enggak. Kapan terdeteksi? Tanpa periksa, tanpa mengetahui CD4 maupun viral load berikan. Lebih awal dimulai, lebih keren nanti hasilnya. Lanjut. Ya, ada juga yang pakai 2 katanya. Ya, tergantung dari ininya. Lanjut. Saya mau ngasih tahu, ini Indonesia ARV Guideline bisa dibaca nanti lanjut. Nah, jadi pertimbangkan kalau mau memulai, kita kan mau mulai nih. Ibu ini positif, reaktif, kita mau memulai terapinya ya, harus kita persiapkan mentalnya. Ya, harus kita persiapkan. Kalau ada infeksi oportunistik, obati dulu. Kemudian apa dikasih yang disebutkan dokter Tambar tadi, saya dapat ini dokter Tambar stadium 2, 3 dan 4. Tadi saya baca stadium 3 dan 4. Kemudian kalau ada koinfeksi tuberkulosis, obati dulu ini 2 sampai 4 minggu ya, baru dimulai pemberian ARV kita. Lanjut. Ini efek samping sudah dijelaskan tadi, lanjut. Nah, rute persalinan. Rute persalinan yang paling aman tetap adalah pervaginam, paling aman. Tetapi kadang-kadang tidak bisa pervaginam kalau masih mana dia? Belum makan obat sekian atau viral loadnya masih di atas ini. Padahal kita tahu dari rute persalinan penularannya bisa sampai 20%. Namun kalau udah kita pakai ARV-nya 6 bulan, mudah-mudahan ini bisa kita pakai. Ya, kalau enggak memenuhi persyaratan ini masih tetap dilakukan seksio sesaria. Seksio sesaria ini jangan kita anggap menyelesaikan semua masalah. Malah dia menimbulkan masalah yang lebih besar lagi kemudian hari. Dan banyak sekali terjadi sekarang di dunia masalah yang ditimbulkan pada pasien-pasien bekas seksio sesaria. Lanjut. Lanjut Bang. Breastfeeding. Menyusui. Kan kita bilang cairan tubuh. Ada di ASI? Ada. Ya. Tetapi kalau sudah makan ARV mudah-mudahan tak terdeteksi lagi. Boleh memberikan ASI, saya juga baru dengar ini, boleh katanya. Namun kita lihat resiko infeksinya sangat tergantung daripada viral load. Kalau udah nggak terdeteksi lagi, ini ya penyakit-penyakit emaknya lah sampai kepada luka di putingnya atau di mulutnya. Ini rekomendasi WHO ini ASI eksklusif. Sampai nanti memberikan ASI 12 bulan. Lanjut. Ya, jadi kalau kita bilang bayi-bayi yang dilahirkan dari ibu HIV ini memang harus lebih care kita kepada ibu tersebut ya. Ngapain kita kalau dia very low resikonya kasih profilaksis zidofudin, akan dibagi nanti ini very low sampai kepada yang tinggi risikonya. Lanjut, slide. Ini guideline ini nggak asal saya bilang lagi, cuman saya bilang ini. Kalau sampai 6 minggu anak yang dilahirkan tadi belum ketahuan sakit atau enggak, reaktif atau enggak, tetap dikasih ARV-nya sampai 12 bulan. Mana dia ini 12 bulan. Tapi kita ingatkan sama keluarganya, nanti dipikirnya udah 12 bulan anakku dikasih obat, udah baik lah ini, enggak. Bahwa profilaksis yang kita berikan cotrimoxazole tadi bukan untuk menyembuhkan HIV, tetapi untuk mencegah infeksi. Ada banyak ini dia pikir udah dikasihnya obat, udah sembuh anakku, enggak ya. Hanya untuk mencegah infeksi. Lanjut, next slide. Ini myriad, ini hanya bagaimana kita menangani pasien. Misalnya, udah pasien yang lama ini, tetap kita tes juga. Bagaimana kalau pasien baru dapat dia, tetap kita tes juga. Saya pikir ini yang dapat saya berikan pada pagi hari ini, semoga bermanfaat. Pesannya hanya satu, semua ibu hamil wajib tes HIV-nya. Itu pesannya. Kapan dites? Kapan dia datang. Paling bagus kapan? Trimester 1. Mudah-mudahan itu bekal yang bisa kita bawa pulang ke tempat kita masing-masing. Terima kasih.
Terima kasih pada Prof. Sarma untuk presentasinya sangat informatif dan aplikatif. Selanjutnya kita sampai kepada sesi tanya jawab kepada Prof. Sarma dan Dr. Tambar, kami persilahkan ke depan. Kepada para peserta, silahkan mengajukan pertanyaan seperti tadi, karena memang untuk sejawat dokter yang ada tugas di FKTP, Puskesmas ini menjadi ujung tombak agar kita bisa mencapai target-target daripada pemerintah tadi di tahun 2030. Silakan. Silakan Dr. Christine. Dr. Christine akan mengajukan pertanyaan.
Terima kasih Prof. Sarma, Dr. Tambar untuk presentasinya yang sangat menarik. Ya tadi disampaikan tentang penggunaan ARV yang memang sebaiknya diberikan sedini mungkin. Nah tetapi yang ingin saya tanyakan berkaitan dengan CD4 yang sangat rendah mungkin di bawah 200. Ini pertanyaan untuk Dr. Tambar dengan Prof. Sarma. Kira-kira seberapa efektif penggunaan ARV pada keadaan demikian? Terima kasih.
Dr. Tambar.
Terima kasih untuk pertanyaannya ya. Jadi sebetulnya pemberian ARV itu bisa pada semua level CD4 ya. Mau level berapapun bisa kita berikan. Hanya memang kalau kita bandingkan ya, pasien itu CD4-nya di bawah 200, yang satu di atas 200 ya. Biasanya yang di atas 200 itu lebih cepat CD4-nya meningkat. Ya, kita tahu bahwa viral load turun, CD4 akan naik. Itu lazim seperti itu ya, karena tadi kita tahu HIV itu menginfeksi sel-sel yang mengandung CD4, limfosit CD4, dia masuknya ke sana sehingga limfosit ini akan turun akibat infeksi HIV ini. Dia bereplikasi maka CD4 ini turun. Begitu kita berikan ARV akan cepat naik. Kalau dibilang tadi di bawah 200 ya dia naik juga gitu ya. Hanya mungkin kecepatannya kalau dia tadi di bawah di atas 200 viral load-nya itu mungkin lebih cepat dia tak terdeteksi dibandingkan yang pasien CD4-nya itu di bawah 200. Itu barangkali jawaban saya. Terima kasih.
Dr. Sarma, Prof. Sarma,
Baik.
mungkin ada tambahan.
Dr. Christine, terima kasih. Kalau saya beranggapan seperti ini, dalam setiap tindakan, mana yang lebih banyak untungnya atau ruginya? Kalau enggak kita mulai, CD4 enggak akan naik-naik, viral load enggak akan turun. Memang penelitian menyebutkan kayak gitu, bahwa kalau dia lebih tinggi CD4-nya, viral load-nya nanti akan cepat turun dengan pemberian ARV. Enggak mungkin kita tunggu-tunggu kapan naiknya dia. malah mungkin nanti makin turun. Makanya pengobatan itu disebutkan sekarang terdeteksi, langsung sekarang kasih pengobatan tanpa memandang CD4. Itu saya pikir tambahan dari saya. Terima kasih.
Ada tambahan sedikit ya. Kalau dia CD4-nya di bawah 200, ada yang disebut imunorekonstitusi inflammatory syndrome. Nah, atau IRIS. Nah, pada pasien yang CD4-nya di bawah 200, kita berpikir sebagai dokter, jangan-jangan nanti ini muncul IRIS gitu. Di mana kondisi IRIS ini, pasien itu semakin buruk kondisinya sesudah pemberian obat ARV ini. Mungkin 2 minggu pemberian atau 3 minggu pemberian, kok kondisinya memburuk gitu ya. Itu pada CD4 yang rendah kita berikan. Jadi kita berpikir ke arah sana. Nah, kondisi ini tidak akan menghentikan ARV. ARV-nya kita tetap teruskan, tetapi kita berikan kortikosteroid untuk menanganinya. Sebetulnya itu karena imun responnya baik. Terima kasih.
Terima kasih Dr. Tambar. Ada pertanyaan yang berikutnya, silakan.
Baik, terima kasih dokter dan Prof. Perkenalkan, nama saya Riki Storus, saya dari Istanbul 18. Ingin bertanya dengan Prof. Sarma, seandainya misalnya ada kasus di kemudian hari seorang pasien ibu hamil di trimester pertama dia positif dengan HIV-nya, kemudian kita pasti akan memberikan ARV untuk selama 6 bulan tadi. Nah, kalaupun misalnya pasien-pasien ini kan ada yang bandel, ada yang baik. Di 1 bulan, 2 bulan pertama dia minum, terus di bulan ketiga, keempatnya dia tidak minum. Apa yang mau kita lakukan dok untuk mengejar CD4 untuk meningkat lagi begitu? Terima kasih Prof.
Ya, silakan Prof.
Jadi kayak gini, kita itu di puskesmas ya, nggak usah kan untuk HIV, untuk HB, hemoglobin kita sekarang, HB ibu hamil itu tinggi kali yang anemi. Jadi saya suka bilang ke vaskes primer, coba buat inovasi supaya ibu itu ternyata kita teliti yang nggak dimakannya. Tablet tambah darah yang kita berikan, berikanlah tablet tambah darah 90 karena itu ya. 90 tablet selama hamil. Ternyata nggak dimakan. Jadi sebagai dokter, kan kita adakan KTI mengadakan penelitian-penelitian. Anak-anak saya penelitian, bukan anak biologis ya, anak kayak kalian. Kita buat inovasi, misalnya kayak gini. Pagi-pagi ada grup WA ini kita bikin. Ayo makan obat apa, tambah darah, dia makan. Kita teliti di situ, tak ada lagi yang anemi, naik semua HB-nya. Jadi kalau kita bilang pasien yang kayak gini kan yang bandel ini, jogal ya. Siapa yang salah? Kita juga ada andil kita salah. Makanya kita bilang kita memulai ARV janji keras ya. Akan kasih salah satu metode. Metode yang lain buat cara supaya dia jangan bandel. Sekarang pertanyaannya mau diapain Bu ini? Sebelum saya lupa, bukan 6 bulan aja sayangnya. Seumur hidupnya dia makan ARV. Seumur hidupnya. Cuma 6 bulan yang teratur itu supaya bisa pervaginam. Itu yang mau kita apa nanti. Jadi kalau kita bilang apa yang mau kita lakukan untuk itu, saya pun gak tahu jawabnya. Kalian dokter Tambar yang bisa jawab. Kalau 1 bulan dimakan kemudian gak makan lagi, kita mulai lagi atau teruskan, bagaimana ini minta apa ini? Call a friend atau minta bantuan. Silakan dokter Tambar.
Jadi kita juga harus tahu ya, obat ARV itu punya efek samping. Jadi kita harus bertanya, jadi kita buat komunikasi dengan ibu tersebut. Alasannya dia menghentikan obat itu apa gitu ya. Jangan-jangan karena ada efek samping ya. Sehingga pada awal-awal mendapatkan ARV itu kita harus edukasi bahwa itu akan ada efek samping pasien-pasien yang mendapatkan obat ARV. Bayangkan antiretroviral itu 3 jenis kita berikan ya. Saya dulu sebelum berkecimpung di bidang infeksi HIV ini, untuk hepatitis B saja, 1 saja obat anti virusnya yang diberikan, saya berpikir aduh bagaimana ini begitu ya. Misalnya hepatitis B yang harus makan obat juga seumur hidup ya. Nah ini 3 obat ya. Kita lihat pasien-pasien itu belum lagi nanti pada saat dia makan obat, resiko Stephen Johnson ada ya. Nah, sehingga kita perlu edukasi. Hanya efek samping itu memang pada awal-awal makan obat dia. Mungkin 2-3 minggu. Sesudah itu mungkin dia sudah bisa adaptasi, ya, sudah bisa ditoleransinya obat ARV tersebut. Jadi perlu komunikasi ya dengan ibu tersebut ya, supaya kita bisa memfollow up apa alasan dia menghentikan obat gitu ya. Bukan mungkin karena efek samping itu. Jadi kalau ada efek samping kita atasi efek sampingnya. Itu barangkali tambahan, Prof.
Terima kasih. Ada lagi pertanyaan? Ya, silakan dari sisi kiri kami. Mic-nya ya?
Baik, selamat siang dokter. Izin dokter, perkenalkan nama saya JSKL Juwarsan Sipayung. Saya mahasiswa koas. Ingin bertanya dokter kepada dokter Tambar Kembaran. Izin dokter, apakah perlu ketika kita meninjau bahwa sebagai dokter yang mungkin kita akan bekerja di layanan triase seperti di IGD, sama juga peluang untuk terinfeksi HIV dengan hepatitis B kan dari darah. Jadi kalau untuk hepatitis B kita emang udah bisa vaksin, dan pertanyaannya apakah perlu profilaksis yang kita berikan kepada tenaga kesehatan yang juga berisiko, terutama pada dokter-dokter umum yang kita tidak tahu bagaimana pasien riwayatnya, dan dia datang ke IGD mungkin dalam keadaan trauma berat, ada banyak perdarahan, dan kita pasti kontak langsung dan terpapar banyak. Pasti akan terjadi kontak yang banyak dokter. Apakah perlu dan apakah sudah ada perencanaan dari bagian HIV untuk mengedukasi dan memberikan profilaksis PrEP tersebut kepada dokter-dokter di IGD dan terutama orang-orang yang di lapangan dokter. Mungkin itu pertanyaan saya dokter, terima kasih dokter.
Iya, ini ya, apakah perlu PrEP pada tadi udah disebutkan ya, yang diberikan PrEP itu adalah yang transmisinya lewat seksual ya. Tadi kan itu tadi syarat-syaratnya ya, LSL, waria gitu ya. Jadi kalau transmisinya lewat yang lain itu tidak diberikan PrEP ya. Yang diberikan itu adalah post exposure. Jadi sesudah dia tertusuk jarum seperti itu ya, baru kita berikan profilaksis. Yang PrEP tadi itu hanya untuk pasien yang transmisinya melalui hubungan seksual. Nah, itu saja Indonesia baru mengadopsi 2021 ya, dan ini masih belum semua di layanan ada, masih berupa pilot project seperti itu ya, di beberapa mungkin di Jakarta atau beberapa kota yang ada ya. Jadi sedangkan WHO itu menganjurkan itu dari 2016 ya, pre-exposure itu diberikan gitu ya. Jadi kalau untuk karena kecelakaan kerja itu post exposure, dan itu diberikan nanti selama 28 atau 30 hari. Jadi 1 bulan dia memakan obat ARV ya. Jadi tidak diindikasikan untuk ini ya, untuk transmisi lewat cara yang lain. Terima kasih.
Terima kasih Dokter Tambar. Ada lagi? Mungkin ini pertanyaan terakhir. Silakan.
Baik, perkenalkan saya Florence Sotmian Theodora. Saya mahasiswa profesi dokter. Di sini saya izin bertanya kepada Dokter Tambar. Tadi kan seperti pengobatan pada HIV, AIDS, bagaimana pada kondisi pasien dalam pengobatan ataupun penyertanya itu autoimun seperti ITP, RA ataupun sarkoidosis. Nah, pada keadaan ini kan kortikosteroid bisa bersifat imunosupresif. Nah, pada pengobatan dia terkena AIDS, bagaimana pengobatannya? Apakah itu ada khusus? Apakah kita menunggu viral load atau kita menghentikan dulu kortikosteroidnya atau kita bisa bersamaan? Kalaupun bersamaan, bagaimana sebaiknya cara pemberiannya pada orang yang memiliki autoimun dan AIDS? Terima kasih dokter.
Iya, pada pasien dengan autoimun, dokter, bagaimana pemberian?
Ya, oke, baik, terima kasih. Sebetulnya pada pasien HIV itu tidak ada kontraindikasi pemberian kortikosteroid, ya. Jadi boleh diberikan. Ya, jadi seandainya pun dia penderita autoimun, ITP, SLE seperti itu atau yang lain yang menggunakan kortikosteroid tidak masalah, ya. Jadi ARV itu tetap kita berikan pada pasien-pasien yang terinfeksi HIV, ya. Malah ya kalau pasien-pasien HIV dengan kondisi berat, misalnya ada PCP ya, infeksi oportunistik PCP itu pneumocystis carinii pneumonia ya. Itu kortikosteroid itu kalau kondisi berat ya, itu kalau ada kita periksa analisa gas darahnya PaO2-nya itu di bawah 70 harus diberikan kortikosteroid. Ya, jadi bukan kontraindikasi ya. Sering juga pasien-pasien kita misalnya HIV dengan perikarditis tuberkulosis ya, itu juga harus diberikan kortikosteroid. Kalau tidak nanti ininya ya perikatnya tidak ini lagi nanti gitu ya, tidak baik lagi kondisinya gitu ya, terjadi fibrosis di situ tentu akan bermasalah buat jantungnya untuk seumur hidup gitu ya. Jadi tidak ada kontraindikasi pemberian kortikosteroid pada penderita HIV. Terima kasih.
Terima kasih pada Dr. Tambar. Kita sudah sampai pada sesi terakhir dari acara ini. Izinkan saya untuk menyimpulkan, Dokter, Prof, dari keterangan kedua narasumber kita, tadi ada poin yang atau kata-kata yang sering diulang tadi yaitu edukasi. Edukasi, jadi hal-hal yang ditanyakan tadi perlu kita edukasi pasiennya supaya target-target yang bisa kita capai tadi bisa kita dapatkan. Saya rasa itu Prof dan Dokter Tambar, terima kasih untuk pembelajaran kepada kami semua. Kita beri aplaus kepada kedua narasumber kita.
Thank you Mrs. Helena Rugun, Mrs. Tambar Kembaran, and Professor Sarma Lumban Raja for the informative and insightful presentation and discussion, and Mr. Marwatas as our moderator. And thanks to all plenary lecture and symposium speakers and to all moderators in this 2 days second NoHMSIC. Allow me to invite all the speakers and moderators to come to the front stage.